So, good evening, everyone. First of all,
A
as
very
my
good
roots,
evening.
yeah. So, as my roots belong from the Maharashtra, okay. So today, as we are celebrating the spirit of Ganesh Utsav, and let me begin with this Fertilogix webinar series by wishing you all happy Ganesh Chaturthi. So, my request is please be on mute, Nand Kishore. Hello, technical team, I request to be on mute, please. Mr. Nand Kishore, thank you. So yes, so wishing you all very happy Ganesh Chaturthi. So I am Rishikesh Chaudhary, a group product manager at Universal NutriScience, and it's my true privilege to welcome you all for this Fertilogix webinar series. It's a collaborative academic initiative with MPSR and UNS. And at the outset, I extend my heartfelt thanks to our program director, Madam Archana Base, MPSR and Uttarakhand ISAR chapter for their invaluable support for making this event possible. And at UNS, we usually take pride for being India's fastest growing nutraceutical company. This year, especially, we are celebrating a significant 25 years of milestone for CoQ, which is India's first and most trusted coenzyme Q10 bank. With our leadership in gynae fraternity, that's Primoza in EPO market, and our recent blockbuster joining us. With that, I now hand over the session to Dr. Suti Sodhurahe. Dr. Suti, over to you.
Yeah, thank you so much, Rishikesh sir. So good evening to all the esteemed faculty members. My name is Dr. Shruti Patwal and I'm from the Medical Affairs team of Universal NutriScience. And on behalf of the entire team at UNS, we welcome you to the fourth series of Fertilogix based on adenomyosis and endometriosis, unraveling the overlaps. This wouldn't have been possible obviously without Dr. Archana Baser ma'am and also the support and guidance of Dr. Akriti Gupta ma'am, Dr. Kalyani Srimali ma'am and Dr. Rudri Agarwal ma'am. So Dr. Akriti Gupta ma'am is the Assistant Professor for Reproductive Medicine and Surgery at Sri Mahant Indiresh Hospital and Medical College, Dehradun. She has been associated as a life member for various organizations including FOXY, ISAR, IFS, IAGE and PCOS Society. She also has several achievements to her name including being the current treasurer for Dehradun FOXY 2024 to 2025. Dr. Kalyani ma'am has a rich experience of more than 17 years in infertility and reproductive medicine. She's also the clinical director and senior consultant of reproductive medicine at Nova IVF Indore and Ratlam. She also has several awards and recognitions to her name. She has been a professional member affiliated with various organizations including FOXY, MPIEGE, IOGS, ISHRE and so on. She has also contributed to various book chapters and index journal articles. Dr. Rudri Agarwal ma'am is also a part of Nova IVF Fertility Center. She also has several awards and recognitions to her name, including being the university topper in her MS and so on. She is also associated with IOGS, ISHRE, ASRM and so on. So with this, I would like to hand over to Dr. Rudri ma'am and Dr. Akriti ma'am.
Thank you so much, Dr. Shruti. I'll firstly extend a very warm welcome to all our esteemed faculty and also the delegates who have joined in for this exciting webinar series we are holding. And I'm really thankful to Archa Basan ma'am who has given me this opportunity to carry forward the webinar. And so today, as we discussed, we are discussing the theme that is adenomyosis and endometriosis, unraveling the overlaps. So let's first begin the session by taking the blessings of Saraswati Mata. So could you please play the Saraswati Vandana, Shruti?
Ya kundendu tushar धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः विचारसार परमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
I now request Dr. Rudri to please introduce our director of the series, Dr. Archana Bassar, and proceed with the session.
UNS for the kind words of introduction. So, welcome to the yet another episode of Fertilogix series, and let me proceed with the further events. I warmly welcome the Can we have the CV of Dr. Archana ma'am, please?
Dr. Rudri is audible.
Okay, so Dr. Archana Bassar ma'am is the senior most ART consultant and a senior obstetrician and gynecologist of Indore. She is director at Akash Hospital, Indore. And very, very important, ma'am is the Foxy presidential candidate for the election year 2026. So we extend our warm wishes for the coming election year to ma'am. And to introduce further, ma'am is presently holding the position of chairperson of MP chapter of ISA 2025-27. Ma'am is also fellow representative of AICC RCOG West Zone. She is a joint secretary of ISA 2025-27. She has been organizing secretary for AICOG 2021 Indore. Further adding to her cap, she has held various prestigious past positions as the chairperson of Foxy Imaging Committee 2015-17. She has been an organizing secretary of ISA 2016, a managing committee member of ISA 2018-20, Imaging Science member of EFOG, managing Imaging Science Committee chair EFOG 2022-23. We extend warm welcome to you, ma'am, and I request you to take the session further and introduce our chief guest and guest of honor for our delegates. Thank you, ma'am.
Hi, good evening, everyone. At the outset, let me welcome you all from the Uttarakhand to this Fertilogix series of MP chapter ISAR webinars. And I'm really glad to see everyone here, Dr. Jyoti Sharma, Dr. Jaya Chaturvedi, Dr. Akriti, who has been instrumental in connecting us to all at Uttarakhand, Dr. Rudri Kalyani, and my dear friend, Dr. Meenu Vaishya. I'm sure she'll be joining soon if she's not here. Dr. Oli, Upendra Oli, Dr. Vinita. So all of you have really given time from your clinical commitments. And I'm sure we'll be soon getting joined by Aarti, Anupama, Surbhi, Anuja, Shweta, Anushri, Kanika, Sangeeta, Ruchika, Richi, and Shilpi. So all of you all, a great welcome to this webinar series. And I think as I was talking to Dr. Jyoti, that this is a very important topic which we have taken. Like endometriosis is a subject which is still an enigma. I mean, every day there has been something new happening, new molecule is coming, and there is so much of overlap between whenever the pelvic pain problem is there are a lot of differential diagnoses you have to keep, and there are different challenges with the endometriosis, and especially nowadays when it is coming and getting diagnosed in younger and younger women. You don't know, they have a long reproductive life ahead of them, and they have a deep invasive endometriosis. Really, how to manage it, how to really counsel them for extensive procedures. I think this all will come up in the panel discussion, and we have to bless us and give us advise on our series Dr. Jyoti Sharma as a chief guest with us. May I have the CV of Dr. Jyoti Sharma?
Dr. Archana ma'am, you're on mute actually.
Thank you, Shruti. So, Dr. Jyoti is past president Dehradun Obs and Gynae Society, and she is practicing gynecologist since 1980. And she has a special interest in infertility and high-risk obstetrics. She has Lifetime Achievement Award in 2018 from IMA, and she has won Governor's Award in 2005, organized various free camps in Badrinath and Kedarnath, very difficult territory, and she has participated in various national conferences as faculty. And I'm really glad that, Madam, I'm meeting you here today on this platform and to take your advice and your guidance and your blessings. So over to you for your words of wisdom, Dr. Jyoti.
Namaskar to all the delegates, and I'm extremely thankful for inviting me as a chief guest in your very prestigious session. The only thing which I would want to say about this, I've been saying that changing scenarios since maybe last 45, 50 years. And, so many times people were opened up for acute abdomens, and then they were found that absolute frozen pelvis, not much could be done at that. I'm talking about 50 years back, and perhaps just a little adhesiolysis, and then the abdomen was perhaps closed, even in medical colleges when they could not, and they were invariably considered as tuberculosis, or since tuberculosis is also such a common disease in our country. So the stepwise increase in the diagnosis and the treatment and the various modalities which have come into play for this particular disease, which is, as you say, it's very elusive. And now we are coming across children in their teenage, say it's a few years of their menstrual cycle, and then it is being diagnosed. And fortunately, we can offer them something at that tender age, which prevents them to go into the more serious aspect of the disease. And I don't know, कभी इंजेक्शंस आ जाते हैं, कभी ऑपरेशन वाले कहते हैं भैया दिस इज द गोल्ड स्टैंडर्ड, द मेडिकल पीपल से दिस इज द गोल्ड स्टैंडर्ड, सम पीपल से combination of the medicine is on surgery is a gold standard. So this perhaps is something which is a genetic thing which is happening inside a mother's womb, in the transcelomic changes in the transcelomic epithelium. Now how that is going to be targeted, only God knows. So, but I'm sure science will come up with more and more. But with this new molecule which has come since about 2-3 years, maybe this is showing promising results. But time shall reveal what the result, because it's 2 or 3 or 4 years is peanuts. It's a very small time to give opinion on any particular drug. And of course, you have heroic surgeons, heroic surgeries, doing all sorts of bowel transplants, ureteric transplants, and God knows what. But if only we could nip it in the bud and not allow it to take this massive form, which is a cause of morbidity and even mortality in many women. And of course, infertility, despite the fact that we are an overpopulated country, but this is a very common cause of sickness in women. And I really wish that there is some sort of magic which happens, and we are able to find out a clue which we can start even before the woman starts having a menses. So a lot of congratulations to the efforts which have been put into this particular webinar, and I wish everybody a lot of success. God bless. And I just had an emergency. Actually, I have to rush. I just wanted to come and give my thanks and bless all the younger generations to continue doing the good work that they are doing. God bless all of you.
Thank you, Dr. Jyoti Sharma. Thank you so much from bottom of my heart that you have come in emergency, and really you brought out a very important point that we have to nip it before it hit us.
Yes.
That's the key message from your inputs and your advice. I think that's an experience is telling us. So your experience definitely is really tremendous. And yes, it was used to get confused with PID because of the tuberculosis. Now we know that this is separately. Previously, it was thought that it's only a disease of the affluent society. It cannot happen in our country, but now we know that it's nothing to do with affluence or like less economically solid people. It can happen to anywhere. It is again ubiquitous. Anybody can suffer with it. So we really need to find out the diagnosis, solution, and during intrauterine life, if we can prevent it.
We can.
That's a research subject. You are given a topic for research to take generation. So thank you very much, Dr. Jyoti. I will not hold you long. So thank you so much.
Ramji.
Ram. And so Abhi, let's meet Dr. Jaya Chaturvedi. We just met her. She was still in her office chair because she has to be there. So can I have CV of Dr. Jaya Chaturvedi? I think Jaya ji is Dean Academics, Professor and Head of the Department of Obstetrics and Gynecology, All India Institute of Medical Sciences, Rishikesh, again a holy place. And she was formerly Professor and HOD at HIMS Dehradun. And affiliation, she's patron Uttarakhand Obs and Gynae Society, advisor of Dehradun Obs and Gynae Society. And once you're like Dean, I know that your academics are so many academic achievements that it's very like challenging to read it in the one slide, but really you've done a great job to put everything in one slide. You have published and presented 78 papers in various journals and conferences, and you are reviewer in Obs and Gynae journals, and lots of awards and honors are there with Dr. Jaya Chaturvedi. So I will not come in between Dr. Jaya Chaturvedi's advice and me. So over to you, Dr. Jaya, for your advice, inputs, and what do you think about this topic?
So thank you, Dr. Archana. First of all, good evening, everyone. And I thank Team MPSR and UNS for this collaborative webinar series, which is planned with great logic. And in fertility, when we will apply logics, we can do wonders. So the topic taken with the name, means first thing, the webinar taken with the name Fertilogix is very, very catchy. So I congratulate for the name also. And after that, the topic which we are taking today, as Dr. Jyoti highlighted, is really an enigma. And it's a cause for lot of mortality nahi hoti, but morbidity. The patient suffers a lot with this morbidity from the beginning till their end of the reproductive age. So what we have to do is we have to pitch in. The theories are lot many. So what is the best development theory? We have to see, go inside to it and take counter for that. So theories are there. Then after that, lot of treatment, as Dr. Jyoti and Dr. Archana both highlighted, surgery, medicine, what is most important, by which we should diagnose it properly, whether it is MRI. We are going to discuss about the ultrasound findings of adenomyosis and MRI findings in the in such cases. Then you are going to discuss about the overlapping of both the diseases which are concomitantly found in one patient. And then that patient is coming to us with infertility, with lot of pelvic pain, with lot of adhesions. So what should be the right treatment? Whether we should start with the medicine whether we should go straight ahead for the surgery first and after that the medication will be continued should be discussed in this webinar. So all the best for this, means all the lectures and especially the panel discussion which is going to happen with all the stalwarts who are present here. And thank you so much for inviting me. It's an honor for me, not as guest of honor for me to attend this webinar. Thank you so much.
Thank you, Jayaji. Thank you so much for your time, precious time, and your advice on this topic. I think this is a very important topic. And please stay with us when we are discussing. And I
will like to listen, but I'll see.
Yeah. So thank you so much. Yeah. Thank you so much. And over to coordinators to take it further.
As we move on to the first session of the evening, that is the session on adenomyosis, ultrasound and MRI, I would like to welcome our esteemed chairpersons for the session 1, Dr. Vinita Gupta. Can we have the slides, please? And Dr. Upendra Oli, sir. She is professor and head of the Department of OPG Gynae at SGRR Institute of Medical and Health Sciences at Dehradun. With a teaching experience of 27 years, she has more than 80 publications to her credit, and she's also been awarded the Doom Diva Award and Health Icon Award from Times of India. She's also been the organizing secretary at North Zone Yuva Foxy Conference held at 2018 at Dehradun. Welcome, ma'am. Dr. Upendra Oli, sir, he is the head and the director of Oli Hospital, Infertility Research and Diagnostic Center, Haldwani, and he's practicing as an infertility consultant. Also, he has taken training from Director Fertility School, Mumbai. He is also life member of ISAR IFS, and he has been the president of IMA Haldwani 2023-2024, and also received many awards to his credit. We welcome you, sir. I now request Archana Basar ma'am, please proceed with the first talk.
Okay. Thank you very much, Akriti. And thank you, Dr. Vinita and Dr. Upendra, for giving your precious time to chair the session. May I be allowed to share my slides, please? Akriti, are my slides visible, dear? Hello?
Yes.
Yes, ma'am.
Yes. Okay. So, good evening once again. My topic today is ultrasound and MRI in adenomyosis. So, ultrasound in adenomyosis, this is the scope of my talk. It helps in diagnosis and during intraoperative use of ultrasound in adenomyosis, MUSA criteria, Delphi revision, MRI, learning points, and summary. These are the points I'll be talking and taking you through. Let's look at the adenomyosis and what the wonders pelvic imaging has done. Pelvic sonography remains the imaging modality of choice for initial evaluation of myometrial pathology. This is something which is very important, which as an obstetrician gynecologist, we have to realize and understand, because if you want to see the endometrium, you can see by hysteroscopy. If you want to see the surface of the uterus, fallopian tube and ovary, you can put in a laparoscope and you can see. But to see the myometrium, you have one modality, that is ultrasonography. So that is very important, and we all know that myometrium plays a very important role in fertility and during pregnancy as well. Myometrium holds everything. So the advent of vaginal sonography and color Doppler sonography have allowed for major refinements in detection and accurate diagnosis of common disorders affecting the uterus. So these are the two main pathologies of the myometrium: myoma, myofibroids, and adenomyosis. So let's just look at briefly about the normal, and then we go on to the abnormal. I should not talk to this audience about the anatomy of the layers of the uterus, but just like you have outer myometrium, inner myometrium, endometrium functionalis, and endometrium basalis. This is how the thing is, and this is the histology or view of uterus cut. Now let's move on to the ultrasonographic anatomy. When we do a transvaginal probe in the sagittal section, what you see, this is the serosa, this is the myometrium, and this is the endometrium. And you just a pictorial diagram of it. This is the stratum functionalis, this is stratum basalis, this is inner myometrial junction, and this is the outer myometrium. If you look here, the distance between the anterior myometrial wall and the posterior myometrial wall from the endometrium is almost equal. So we learn about it in next slides. What is the meaning of this being equal and unequal? Now these are the myometrial layers. If you look here, this is the outer layer of the myometrium. This is the middle layer of the myometrium, and this is the inner, or that is the junctional zone, and this is the endometrium, which is in the luteal phase. That is some progesterone effect is there, and this is the serosa. So this is about how you have to learn about the gray colors on the ultrasound, so that you know that where actually the disease is, because that will help you in different classification of adenomyosis. This is again the normal anatomy. This is the normal endomyojunction, and with the colors, spectrum of colors, and look at this picture here. This is a loss of endomyojunction, and this is adenomyosis with little vention blind appearance, and there's a lot of the shape is a little globular shape of the adenomyosis. And this is again a normal endomyojunction in endometrium. And these are the two pathologies here. This is the adenomyosis, and these are the fibroids. Like how the fibroids can be anywhere, it can be submucous, it can be subserous. Adenomyosis is mostly in the myometrium, but it can be in the inner outer zone of myometrium. So adenomyosis is a common benign uterine pathology that occurs when the cells that normally lines the uterus grows into the layer of muscles in the wall. And the area of uterus affected by adenomyosis invariably is known as endometrial myometrial junction. So this is adenomyosis. Now, what is the incidence of adenomyosis? As we were discussing offline, that adenomyosis and endometriosis is increasing. And for everyone's information, Asian women have a higher incidence of adenomyosis, and it is asymptomatic in 1/3 of the cases. And what are the symptoms? Women presenting with menorrhagia, dysmenorrhea, pelvic pain, and uterine enlargement. Adenomyosis can be diffuse or focal, and its role in infertility is still debatable, but it is reported with a frequency of association 1 to 14%. Now, what are the ultrasound features of adenomyosis? You know, the first clue of adenomyosis is often an ill-defined lesion within the myometrium. A lesion may have an irregular contour, no rim, no edges, shadows, or a faint-shaped shadow. And other features may include myometrial cyst, hyperechoic island, subendometrial lines and buds, and translesional flow, a thickened, irregular, or ill-defined junctional zone, and myometrial anterior-posterior asymmetry, and enlarged uterus, and vascular arrangement is radial and penetrating. These are the three key signs on ultrasound: ectopic endometrial glands, muscular hyperplasia and hypertrophy, and hypervascularity. This muscular hyperplasia appears as globular uterine enlargement and asymmetrical myometrial thickening, often within the vention lines or streaking shadowing. So these are again the ultrasound features of adenomyosis: asymmetrical myometrial thickening, ill-defined endometrial myometrial interface, linear striation, and increased junctional zone thickness. So look at this. This is a picture when you put a 3D. Now we have a, like with the advent of 3D scans, like you can have a better delineation. So this is the normal endometrial lining, and this is the endomyojunction. And what happens in the adenomyosis, this junction is lost, and this is a loss of endomyojunction here. Again, the loss of endomyojunction on 3D, and this is normal endomyojunction on the 3D. This is a picture of a spectrum of adenomyosis. If you see, the shape of the uterus is enlarged, and then you have different islands here. Different islands are here, and then this distance. When you see this distance is larger than this distance. So this is an inequality in the myometrial size anteriorly and posteriorly. Then again, you have a lot of blood supply and the intramyometrial vascularity. So these vessels are more dilated. They are more dilated than the endometrial vessel. So there is a translesional vascularity rather than in the fibroid where there is a peripheral vascularity. So this is again adenomyosis. Look at the shape of the adenomyosis, Venetian blind appearance, and this is the distance where you have a larger distance here and a smaller distance here. Now, there is a MUSA guideline in 2015. Morphological uterus sonographic assessment consensus was published to standardize terminology and develop accurate and uniform criteria for the ultrasound diagnosis of adenomyosis. It is not no more acceptable that you just write that myometrium is heterogeneous or homogeneous myometrium, or there is just adenomyosis. We all have to talk the same language. So that what they have done, they have come with a consensus where just a positive or negative diagnosis is not enough. You have to have a detailed description of all the lesions identified by the ultrasound, like what you have to write down, whether it is in the anterior wall, posterior wall, left lateral wall, right lateral or fundal, or whether the lesion is focal or diffuse, and the presence or absence of myometrial cyst, degree of involvement and depth of myometrium, and limited to internal portion, invasion of the entire body of the uterus, or invasion reaching the serosa, the volume of the uterus less than 25%, 25 to 50%, or more than 50%, and the size of the lesion. Why it is important? It is important because as we were discussing, if you have to offer any surgical treatment for this patient, this is called mapping. If you have mapped the lesion, it becomes easier for you only to perform the surgery, or someone else is scanning for you and you ask them that please give me a detailed description of the lesion you are reporting, so that it will help me in treating the patient, and if I'm doing a surgery, I can perform a good job for the patient, not leaving the areas behind, and it will help me in counseling the patient how big is the lesion and how much area needs to be operated. What happens in 2022, Delphi revision of MUSA criteria for ultrasound diagnosis of adenomyosis, that divides the ultrasound signs for diagnosis into direct and indirect ones. Because as I said you before in my couple of slides, that there are like a striae, appearance of the cyst, and also what they have done, they have divided those signs into direct and indirect ones, and considering the presence of at least one direct sign as a mandatory criteria for diagnosing the adenomyosis. So what does the Delphi revision did? In this new consensus, the ultrasound characteristics suggestive of adenomyosis proposed in MUSA are divided into direct, like cyst, hypoechoic island, echogenic, subendometrial lines, and buds. And indirect ones are asymmetrical thickening, fan-shaped shadowing, translesional vascularity, globular uterus, irregular junctional zone, and interrupted junctional zone. So diagnosis of adenomyosis is made when at least one direct sign is present. What do they say? That direct sign indicates the presence of ectopic endometrial tissue in the myometrium, while indirect signs are secondary to the presence of endometrial tissue in myometrium, such as muscular hypertrophy, globular uterus, or artifacts and shadowing. Now there is another entity that is we all know is a fibroid, and whenever you are putting your probe, and you have to differentiate between the fibroid and the focal adenoma. So what happens? We know that adenomyoma is ill-defined. There is a central vascularity, and associated feature of adenomyosis will be there. Direct features like cyst, indistinct myometrial endometrial junction, no contour abnormality, no edge shadow. So mind it, fibroid does the contour abnormality of the uterus, while adenomyoma does not distort the contour. It increases the size of the uterus. So this is an appearance of a fibroid. This is a well-defined capsule you see in the fibroid. And what happens in adenomyosis? This is a focal adenomyoma where there is an ill-defined capsule. So that is the difference between the fibroid. And what you see, there is a peripheral vascularity in the fibroid, while there is a diffuse vascularity in the adenomyoma. And there are certain challenging cases as well, where it becomes difficult to diagnose. Initially, this is a 30 years old women, where I was thinking probably I'm not scanning it well. This is an ovary which is adherent to the uterus, and it is an endometriosis. but rescanning again and again, and then putting the 3D and the transfer section, we found that this is the uterus, this is the endometrial lining, and there is a cystic structure inside the uterus, and that has got a content, ground glass content, and this is an adenomyotic cyst. So it is very important whenever you are scanning uterus for the pelvic pain, pelvic pathology, it should be diligently done and with focused. You have to be. This is a focal adenoma, and what is it happening is a Venetian blind appearance, which I have mentioned you earlier. Now, the learning points about the ultrasonography in adenomyosis. It is adenomyosis is defined as the presence of ectopic endometrium within the myometrium. MRI is an accurate tool for diagnosis of adenomyosis and associated condition, but we are not using MRI regularly because it is not that easily accessible, and the cost is high. And with availability of high resolution ultrasound, you can have a nearly very good diagnosis of adenomyosis with actual mapping of adenomyosis. And so, would you be offering MRI to women with adenomyosis? Yes, there are. It can complement your ultrasound in certain cases where, as we are going to unravel that adenomyosis and endometriosis overlapping, when you have to really do an deep invasive endometriosis, adenomyosis, and you really want to know extent of the disease, it is important to offer MRI as well. So sensitivity of transvaginal ultrasound in diagnosing adenomyosis is 80% and specificity is 60%. Nowadays, ultrasound can be used even in operation theater as well. Like treatments have come for adenomyosis. Microablation is now becoming popular, is coming up as a new modality of treatment, and while performing procedure, ultrasound is needed to guide the ablation probe precisely. So that's one more use of ultrasound in adenomyosis. What is microwave ablation? Just a couple of lines on that. It's a minimal invasive procedure used to treat adenomyosis, and microwave ablation offers a uterus preserving treatment option with potential fertility benefits, and the procedure involves using microwave energy to heat and destroy the abnormal tissue, leading to symptom relief and volume reduction. And sensitivity and specificity of MRI in adenomyosis is with negative predictive value 77.5%, is 92.5%, 83.8%, and 89.2% respectively. And its use has grown significantly in recent decades because the problem is increasing, and along with the problems, the treatments are also coming up, and you really have to be very close to the diagnosis and precision when you are talking to the patient and taking her for the treatment. So just to summarize, currently the first line method of diagnosis of adenomyosis is transvaginal ultrasound, which has been shown to be considerably more accurate than transabdominal technique, and it represents a direct, minimally invasive, cost-effective, widely available, and non-contraindicated examination. And another advancement has been the introduction of three-dimensional ultrasound, which is particularly useful in studying adenomyosis, especially for evaluating the junctional zone. So thank you very much for patience listening, and happy Ganpati festival to all of you. Thank you very much.
Thank you, ma'am. Thank you so much for this wonderful and crisp talk. And it's always a treat and delight to hear you and this adenomyosis from your lecture. So thank you so much. Now, can I proceed with the next session, ma'am?
Do you want any comments from the chairperson, Dr. Rudri?
Yes, ma'am. May I request our chairpersons to kindly conclude the session so that we may go ahead then? I request our chairpersons.
Dr.
Dr.
Upendra sir, you are actually on mute, sir.
Yeah. Dr. Vinita ma'am and Dr. Upendra sir.
Thank you, Dr. Archana, for delivering very nice lecture on endometriosis and adenomyosis. As we all know, the transvaginal sonography is the best tool for diagnosing endometriosis, adenomyosis, and fibroid. At least 80% cases are diagnosed very nicely with transvaginal sonography. And only in rare cases, we advise MRI where the ultrasound not reached. So very nicely delivered and very nice ultrasonic pictures we all seen. Thank you, Dr. Archana, for a nice talk.
Thank you,
Thank
Dr. Upendra, for being with us.
Yeah, I think excellent talk by Dr. Archana, and she has she was very precise and to the point, just talking about ultrasound and MRI. So in majority of the cases, I think we can diagnose adenomyosis and fibroid, and even able to differentiate on the basis of ultrasound. But in a few cases, you do require the need of MRI, especially if you are going to operate upon a patient for fibroid mapping or to differentiate between fibroid and adenomyosis. So then it's always better to have a clearer picture in your mind before you actually go for surgery. Even if you're going to do an adenomyomectomy, so it is better you are mentally prepared. Otherwise, sometimes you have taken the patient for myomectomy and it turns out to be a adenomyoma. So that way, MRI also has to be done in a few cases. And I think very nicely highlighted all the points by Dr. Archana. So I congratulate her for the talk.
Thank you, Dr. Vinita, for your inputs and comments on that. I think it's very important that ultrasound is in our armamentarium, which is for gynecologists, what you can say, third hand, and we all can learn and practice it, and we can send our patient home with a diagnosis. But MRI, yes, it will complement and it will be needed. So we have to know, I think we have to triage which cases needs MRI.
Yes.
Rather than just sending everybody for MRI with adenomyosis. So I think that can be done with the help of a good ultrasound.
Definitely. Yeah. Okay.
Thank you, ma'am.
Thank you, ma'am. So thank you, Archana ma'am, and all the respected chairpersons for concluding the session. And it was very, very enlightening session for all the delegates. Now going forward, we have very another important session, which is adenomyosis in IVF. And for that, we have a very eminent speaker amongst none other than Dr. Meenu Vesh madam and two experienced chairpersons to chair the session, Dr. Pratibha Sani and Dr. Rekha Srivastava ma'am. So let me introduce our speaker for today's session, Dr. Meenu Vesh ma'am. Ma'am is at present is president of ISAR Uttarakhand chapter, and she has been the founder president of Uttarakhand Society of OBGY. She has been organizing chairperson of FDCCCon 2024 Dehradun, reviewer of Aspire Journal, executive member of Uttarakhand ART and Surrogacy Board. She has been state president of Uttarakhand chapter, a master trainer of HPV vaccination, further adding to her cap. She is organized advanced laparoscopy workshop in 2023, organized laparoscopic myomectomy workshop in 2029, and so on. Ma'am has a specialization in ART and high-risk pregnancy.
I think it's enough.
Yes, ma'am. Ma'am, actually, there is too much to tell about you. So, just to summarize some things. So, let me have the privilege of introducing our. Yes, ma'am. Another chairperson, Dr. Pratibha Sani, ma'am, amongst us. And ma'am has trained in fertility from Bonn University, Germany. And ma'am has established her own setup in Western UP and Uttarakhand in Dehradun by the name of Sani IVF and Fertility Research Center in 1999. And to her credit, there are multiple awards and publications, and she has been an excellent academic scholar. So we welcome you, ma'am, to chair the session. Next, we have, Dr. Rekha Srivastava, ma'am, as our next chairperson. Ma'am is affiliated to Lajpat Rai Memorial Medical College in Meerut, and presently she is holding the position at Savitri Nursing Home and Research Center as a senior consultant for more than 35 years. And she has special interest in high-risk obstetrics, infertility, endoscopy, and in her special achievement, ma'am has received IMA Presidential Appreciation Award and multiple awards to her credit. Ma'am has multiple paper publications to her credit. We welcome you, ma'am, to chair the session. And I request Dr. Meenu Vesh, ma'am, to continue with the session.
So I'll share my presentation. Let me see.
Welcome, Meenu, on the dais.
Meenu ji, namaskar. We welcome you for the session. Sorry, I have a sore throat, but I think the sessions are going very nicely and they're very informative to us. Still, we are learning so many things for IVF.
Thank you, Dr. Pratibha. Good to see you. And a very good evening, everyone. At the outset, I thank Dr. Archana Basir and her team for giving me opportunity to speak on this very challenging topic. We know this condition is very challenging and very underestimated condition, how it affects fertility. And Dr. Archana has very well explained how to diagnose. Sometimes the diagnosis is difficult. She has very well explained what are the zones, junctional zone, which is we need to understand. So we all know adenomyosis is a very challenging, it presents unique challenges. And in further few minutes, we are going to explore how it affects the fertility and what are the current evidence which support its impact on fertility and what are the strategies to treat adenomyosis and IVF. So let us begin with, so adenomyosis, we all know it is a benign condition defined by the presence of the endometrial glands and stroma within the myometrium, increasingly recognized in women with infertility and those undergoing with assisted reproductive technique. Prevalence among women undergoing IVF is 20 to 25%. Often it coexists with the endometriosis, complicating fertility prognosis. So impact on implantation, miscarriage, and live birth rate documented in recent studies. So what is the etiology? There is alteration in the endometrial function. It is due to the tissue injury and repair. There is a disruption of the endometrial myometrial junction to abnormal invasion of the endometrial tissue. Theory of involving stem cells also work here. There is a chronic inflammation and increased angiogenesis and uterine, which affects the uterine receptivity. There is increased local estrogen production that promotes the disease progression. Diagnosis is, imaging is cornerstone. Transvaginal ultrasound and MRI is the cornerstone for diagnosis. MRI is the gold standard. It has got high sensitivity and specificity for adenomyosis. Histoscopy, biopsy have limited role due to its invasive nature. Use of the uniform diagnostic criteria remains a challenge in clinical practice. What we see, Dr. Archana has already explained, it is a globular uterus. Globular uterus is present and there is a myometrial cyst present. And what we see, there is a thickening of the junctional zone and irregular endometrium lining. What we see, there is a striation is also present. And the myometrial wall, there is a unequal myometrial wall, which Dr. Archana has explained very well. And what we see, there is a increased vascularity on Doppler with penetrating vessels in the affected area. So MRI is the second line examination in the diagnosis of adenomyosis, mainly after a non-conclusive ultrasound evaluation. In addition, MRI can differentiate between the subtypes of adenomyosis. Maximum junction zone, if it is more than 12 mm, it is a high alert. It is a high signal sign for adenomyosis. And irregular junction zone, if the difference is 4 millimeter, difference between the maximum minimum is 4 millimeter, it is a high signal sign. Without the presence of the leiomyoma, ratio of the junction zone, maximum junction zone, and myometrium thickness is more than 40%, then it is a sign of greater disease. What we see, Dr. Archana has beautifully explained. There is another diagram which is showing the MRI and classification of adenomyosis. What we can see here, there is a focal adenomyosis, internal adenomyosis, there is internal asymmetric adenomyosis, there is a symmetric internal adenomyosis. What we see here is a diffuse asymmetric adenomyosis and it is a diffuse symmetric adenomyosis. There is the adenomyoma, which is present in the posterior anterior wall. This is a hemorrhagic myometrial cyst, which Dr. Archana explained very well in showing the ultrasound of one patient. There is a submucous adenomyoma. There is a subserous adenomyoma. There is external adenomyosis also. It is posterior external adenomyosis. This is internal anterior adenomyosis. This external adenomyosis most of the time is associated with deep endometriosis, deep infiltrating endometriosis. It doesn't affect junction zone. So it is another diagram which is showing the MRI. What we see, it is a normal size uterus, a myometrial cyst. We can see here, we can see thickened junction zone, and there is a myometrial cyst also present. This diagram showing that the There's a myoma is present, and there's a thickening of the zone plus myometrial cyst. So what is the epidemiology in the IVF patient? Prevalence in IVF women estimated between the 20 to 30%, more common in women more than 35 years of the age, high co-occurrence with endometriosis up to 50% present, and there is high incidence is diagnosed because of the availability of the high resolution imaging. So this is a diagram which showing the immune macroinvasion of the adenomyotic lesion. What we see, there is inflammatory cytokines increase, interleukin 6, interleukin TNF alpha. What it causes it triggers the macrophages 1 and macrophages 2 arises, and there is the immune response. On another factor is the reactive oxidative stress and epigenetic and genetic factors which contribute to adenomyosis. So it has impact on fertility, may reduce ovarian responsiveness, indirectly chronic inflammation, disruption of the uterine contractility, and sperm transport. We will be discussing how to manage all these things. Reduce endometrial receptivity due to inflammation and fibrosis. There is altered expression of the implantation marker and the increased miscarriage rate linked to the defective endometriosis. IVF outcome is also affected in adenomyosis. There is a lower implantation and clinical pregnancy rate compared to the controls. Increased risk of miscarriage after IVF. Reduced live birth rates despite good quality of the embryo. Greater number of the IVF cycle often required success. The severity and the extent of adenomyosis correlate poorer outcome. What we see, there is another diagram which is showing the pathways involving epithelial mesenchymal transition and the impaired desudation. What we see here is there is local inflammation, there is a mesenchyma epithelium, there is inflammatory interleukin 6 and interleukin 10, TGF beta, all these things causes the fibrosis, and there is a migration, and there is a transition of the mesenchyma and the epithelial layer, which causes fibrosis, and the decidualization is affected. So there is a defective embryo implantation which is due to the chronic inflammatory state which impedes embryo-endometrium crosstalk, distorted vascularization of the fibrosis implantation, and there is a reduced expression of the endometrial receptivity. Adenomyosis may alter uterine peristalsis, that it causes the embryo expulsion risk. Most of the time, adenomyosis is associated with endometriosis, and they have a synergistic adverse effect on fertility. Endometriosis alone impairs oocyte quality, but adenomyosis impairs implantation. Combined pathology results in higher miscarriage rate, IVF outcome poorer than in isolated endometriosis. Management strategies need to address both simultaneously. What we see, there is a systematic review and the meta-analysis was done to study the reproductive obstetrics and the perinatal outcome in women with adenomyosis. What they found, that there is a decreased ovarian response, decreased fertilization rate, and there is an increased cancellation rate of the cycle. On and uterine receptivity and uterine placental interference, what they do, there is a decreased implantation rate, decreased clinical pregnancy rate, and increased miscarriage rate. On placentation, fetal development and birth, it causes the decreased live birth rate, increased incidence of PET, preterm birth, and small for gestation baby, and there is increased chances of PET and increased preterm delivery is there, and there is increased chances of placenta previa, placenta accreta, and IUD is more common in cases of the adenomyosis. As far as office sweeping, there is increased incidence of neonatal and NICU admission. So pregnancy complication we have already discussed. There is a study was done by this thing, reproductive biomedicine online. There was an article which says the effect of the adenomyosis on placental related obstetric complication. They are saying the same thing. There is association between adenomyosis and increased adverse placental function outcome and hypertensive disorder in pregnancy. The study was done, and so far we have discussed how adenomyosis affect the infertility. Now we come to how to manage the fertility in adenomyosis patient. So long-term GnRH agonist downregulation improves outcome. Pre-treatment reduces uterine volume, inflammation, and abnormal peristalsis. Oral contraceptive and progesterone used as adjuvant in selected cases. Combined GnRH agonist and letrozole is emerging drug. Pre-treatment with levonorgestrel intrauterine system in women with adenomyosis is very helpful. Duration of the pre-treatment for 2 to 6 months, crucial for better effectiveness. So, long-term pituitary downregulation prior to IVF in women with endometriosis causes improvement in the quality of the oocytes and embryos. It causes improvement in the uterine receptivity, leading to the better implantation and diminished loss of the very early pregnancy. Cochrane review is there, and which is saying that the long-term pituitary downregulation prior to IVF in women with endometriosis improves in the live birth rate, and there is improvement in the clinical pregnancy rate by 4-fold. And there is another study, it is a very important study, the pilot randomized control trial was done in reproductive biomedicine online journal. What they see, by using low dose letrozole, there is effective for in patient undergoing IVF treatment. Those who are going to embryo transfer by giving a letrozole and LHRH agonist treatment, there is an increased chance of pregnancy. What the letrozole does, there is improvement in the symptoms during treatment with letrozole or GnRH agonist. Dysmenorrhea, menorrhagia, and hemoglobin improves. There is an increased success in IVF. There is another study which was done, which is showing the effect of the pre-treatment with the levonorgestrel releasing intrauterine system on IVF and vitrified warm embryo transfer outcome in women with adenomyosis. What they are saying, the result of this study offers some support for evaluating the effect of pre-treatment with LNG IUS in women with adenomyosis in future randomized control trial. In Isar, Lucknow, I met one of my friend in IVF consultant in Thomas Hospital in UK. She was saying that we used to give 3 to 6 months of IUS, LNG IUS to our patient before transferring, before doing FET. So this is a new thing, and this is very helpful. So there is certain limitation of prolonged down regulation. Assuming diminished response, especially in poor responders. Now of the surgery, adenomyosis, it improves fertility but carries the risk of the uterine rupture. So while doing it has to be microsurgery, and we have to be very careful. The myometrial thickness should be from 9 mm to 15 mm. If it is less than 7 mm, there is increased chances of rupture of uterus during pregnancy. So it is more effective in younger women with focal disease, often combined with medical therapy before IVF. Hysteroscopy most of the time is not of much use, but in pre-FET transfer, hysteroscopy is a must to assess the direction of the cavity, as it is always irregular, and we can assess the length of the cavity, which will ensure smooth transfer. Now we come to the strategies for assisted reproductive technology. The preference for frozen embryo transfer. After GnRH agonist suppression, blastocyst transfer preferred over cleavage embryos. Single embryo transfer reduces miscarriage rate. Pre-implantation genetic testing may increase the outcome in the older women. Individualized protocol based on the extent of the adenomyosis is recommended. There is a retrospective cohort study was done to study the pregnancy outcome after fresh versus vitrified warmed embryo transfer in women with adenomyosis. And what they found, that the vitrified warmed embryo transfer may have a better result, better pregnancy outcome than the fresh embryo transfer among women with adenomyosis. So adenomyosis have an impact on the ovarian stimulation also. Adenomyosis itself doesn't significantly affect the ovarian reserve. Coexistence endometriosis may impair oocyte yield and quality. Stimulation outcome are similar, but pregnancy outcome differ. Anti-inflammatory and hormonal pretreatment may improve ovarian response indirectly. AMH and AFC remain primary predictor of the ovarian response, even in adenomyosis cases. The lifestyle and supportive care play a very important role. Optimizing BMI and metabolic health enhances outcome. Anti-inflammatory diet and lifestyle modification do help in adenomyosis with IVF. Psychological support is important due to the chronic pain and infertility stress. What are the clinical guidelines and consensus? What the SRA guideline says, there is no universal recommendation for management. Management is individualized. GnRH agonist pre-treatment recommended for women with recurrent IVF failure. Adenomyomectomy for selected symptomatic patient with focal disease. Frozen embryo transfer over fresh transfer considered beneficial. More ICT is needed to guide standard management. So, how can we improve the IRT outcome for patient with adenomyosis? There is a special tip. We have to reduce the intraendometrium estradiol concentration using a GnRH agonist or aromatase inhibitor or combination of both. What we have found that adenomyotic tissue has aromatase, which has the capability of converting the adrenal androgen into the estradiol. So even after giving the GnRH agonist, there is an increased estradiol level. So by giving aromatase inhibitor, we can decrease the estradiol level. So this is the algorithm. This is very important. Diagnosis we have made, effect on the fertility, reduce implantation, early pregnancy loss. We all know if patient is less than 35 years, good ovarian reserve, no coexistence of fertility factors in the couple, dysmenorrhea, mild adenomyosis, uterus size is less than 12-week size, diffuse adenomyoma, or severe adenomyosis, uterus size is more than 12-week size, and focal adenomyoma is present. If age is more than 35, poor ovarian reserve, coexistence of fertility factors in couple is there, no dysmenorrhea, IVF is the solution. Long protocol use, we do fresh transfer, but it is preferred to do freeze all and then do FET. This is showing when there is a mild adenomyosis, you do expectant treatment, IUI and IVF, if IVF is needed. In case of the focal and the younger adenomyomectomy, we can do, but the thickness should be more than 9 to 15 mm. If it is less than 7 mm, the high risk of the uterine rupture during pregnancy. If there is a recurrent implantation failure, recurrent pregnancy loss, we should offer surrogacy to our patient. So, another way to improve the success rate in IVF in adenomyosis cases, there is a role of the mid-luteal progesterone in patient having adenomyosis undergoing ART, patient having endometriosis in which serum progesterone levels were below 37.2 nanogram. Live birth rates were 34% per transfer compared with in patient who have a more than that above this cutoff. Cutoff level is nearly 4 times higher compared with patient without endometriosis, that is 10 nanogram. We all know about it. Adenomyosis and endometriosis are sibling. Increased progesterone support may be required in these girls. So there is an increased uterine contraction in adenomyosis. Women with adenomyosis had a different uterine contractile pattern during the menstrual cycle compared with the women without adenomyosis, proposing an etiological mechanism of infertility and dysmenorrhea in patients with adenomyosis. So, uterine contraction coordination could provide a possible new avenue to improve the fertility in patients with adenomyosis. In patients with increased myometrial contraction, oxytocin antagonists such as the atosiban can be tried. I have tried few of in my patient with adenomyosis. I give infusion 2 hours before the embryo transfer. 6.75 milligram in slow transfusion is given before embryo transfer. It has shown some better result compared to no use of atorvastatin. So, but there is no definite studies coming out for use of the atosiban in adenomyosis IVF cases. What are the future direction? Refinement of the diagnostic criteria with 3D ultrasound, AI-based imaging, better stratification of the patient by adenomyosis, focal versus diffuse, development of the targeted medical therapies without side effects, integration of the molecular profiling of personalized approaches, and longitudinal studies to assess cumulative live birth rate. Now we reach to the conclusion. Adenomyosis is a major barrier to successful IVF outcome. Multifactorial mechanism affect implantation, pregnancy rate, and oocyte yields. Combined medical, surgical, and the ART strategies improve outcome. Individualized patient-centered approach is key factor. Ongoing research will refine diagnostic and the therapeutic strategies. Even ESHRE has not come out with proper guidelines for managing adenomyosis. There is a definite managing endometriosis, but not for adenomyosis. Thank you for patience hearing. If you care about what you do and work hard at it, there is not anything you cannot do it if you want to. Adenomyosis is a big enigma, and then when the patient with adenomyosis and endometriosis come, we are in mess. So with hard work, with patience, we can handle them. Thank you for patience hearing.
Hello.
Thank you so much, Meenu ma'am. I would like to now request our chairpersons to please conclude our session.
So, Meenu has presented very well. The entire topic was fully covered, starting from problems to solution. As we already know, adenomyosis can negatively impact IVF outcome. I am audible?
Yeah.
So, diagnosing adenomyosis and treating adenomyosis before IVF is definitely going to improve results. Earlier, results of IVF were not so good because adenomyosis sometimes remained undiagnosed. Now, the diagnosis modalities have come. It has been diagnosed better. It has been treated better, which has increased results of IVF. And moreover, few treatment modalities like minimally invasive, thermal ablation, microwave ablation have improved results of results in IVF, also miscarriage rate. Thank you, Meenu, for such a nice presentation.
Thank you, Rekha ma'am. Thank you, Dr. Rekha.
Thank you very
Dr.
much,
Pratibha.
Meenu.
And thank you for the opportunity.
I just want to add one thing. Like in previous sessions in ESHRE, they have recommended your curcumin, that is turmeric, for endometriosis. Because adenomyosis is also with the chronic inflammation, turmeric is very easily available in the household. One can add regularly, and you see there is a big, great different results if you see without turmeric and with turmeric. So I'm collecting the data to present it. But we have seen definitely curcumin helps to reduce the chronic inflammation so that we can have a good pregnancy rate, low miscarriage rate, and a full-term pregnancy.
Thank you, Pratibha ma'am, for adding this point. This is a very important point.
Dr. Pratibha,
we have seen that the patient on antioxidants and they give a better results.
No, one antioxidant should be there, but curcumin works at the micromolecular level to reduce chronic inflammation. The whole story starts with the chronic inflammation. So we are adding plus one synergistically to reduce the oxidative stress, to reduce chronic inflammation, to reduce the uterine contractility, to increase the implantation rate. So all this will help. Not a single thing can help us, but it is easily available to us. If we take it, it will work as an antioxidant also. And it definitely has a role to reduce the inflammation. So before starting, like what I do is when a patient comes to me, I recommend them to take 1 teaspoon at night with 1 cup of milk. Now, a cup of milk is going to supplement your calcium, thereby decreasing the oxidative stress, plus the curcumin. It is going to start to reduce the chronic inflammation. We have to get benefit to the patient by one way or the other. So before IVF, the standard protocol is, because the ovaries are preserved in these cases, we get good oocytes. Long-term protocol of GnRH analog is recommended in them because we have to reduce the estrogen level. We don't know, but the curcumin has a very, very good result. You see the estrogen level the day she comes to you, and then after the treatment, there is definitely a drop of around 50% of the estrogen level. So automatically you are curing the disease.
Good insight,
Thank you
Dr.
so much,
Pratibha. It's a
Pratibha
very
ma'am.
informative.
It's a new Indian home remedy which we can definitely incorporate.
Yeah, I got
I was
in the ESHRE, when I attended the full workshop on adenomyosis. See, even I was so surprised that we have such a household remedy in our home and we are searching everywhere what to do.
I also request the viewers, they can pour in their questions in the chat box, and our experts here are there to answer their queries. So, gripping ourselves for the third session, that is the panel discussion, an exciting panel discussion by our excellent moderator, Dr. Aarti Luthra, on the twin troubles, adenomyosis and endometriosis. I would like to welcome our moderator for the next session, Dr. Aarti, and our worthy chairpersons, Dr. Anupama Futela ma'am and Dr. Surbhi. Can we please have their CVs? So Dr. Aarti Luthra, she is the Director and Chief Consultant at Luthra Maternity and Infertility Center, Dehradun. And she's the current president of Uttarakhand chapter NIGF and has been the past president at the Dehradun Gynae Obstetric Society. Plus, she's the founder chairperson of our ISAR chapter of Uttarakhand. Welcome, ma'am. And we are awaiting an exciting panel discussion. I would also extend a warm welcome to Anupama Futela ma'am, and she's the current president of Uttarakhand Obstetric of Gynae Society and also the appropriate authority of Uttarakhand State and Surrogacy ART Board. She's also a pioneer in the infertility at Kumaon region. She had gifted the first IVF baby, and she's also been awarded a Best Gynecologist Uttarakhand Award by the Chief Minister in 2022. Welcome, ma'am. Dr. Surbhi Rai, ma'am.
Yeah, please.
Surbhi Rai, ma'am. She's the director of Surbhi Hospital and Test Tube Baby Center, a leading practitioner in Kumaon region. Both of them are practicing in Rudrapur, coincidentally, and madam also holds a 28 years experience in OBGY and reproductive medicine. She has given a lot of numerous talks, and she has been also be the recipient of ISAR Appreciation Award 2023, and also adjudged one of the 100 most powerful women in healthcare in 2024.
A very good evening to everyone. First of all, I must congratulate Dr. Archana for organizing the topic, who's considered to be the pioneer of IVF in Uttarakhand. And yeah, and thank you so much, ma'am, for guiding everyone so actively.
It's a pleasure, and it's such a nice and informative talk actually, and so interesting also. All the eminent speakers have really given us the information. You know, it's a everyday learning process. We are learning something new every day in every patient.
Learning never stops. That's why doctors keep studying all their life.
Yeah, every gynecologist.
The concepts keep changing. I was talking to my colleague that about 20 years ago, a very famous gynecologist, they opened a young lady, just 20 years old, who had very bad dysmenorrhea. And first, the lap was put in. This was in around maybe 2002. So they said the uterus is very large, because in those days, the laparoscopic sharers and all harmonic, everything was not available. And then she was opened, and the consultant said, oh, this is adenomyosis. I don't think we should touch it, because otherwise she'll lose her uterus. And poor lady, ultimately, she went to an institute for hysterectomy because no one wanted to touch a young girl. So those were the days. But now we are so lucky that science has progressed so much, and our diagnostic devices are so accurate that we can locate which part is the worst part of uterus, and we can remove that. We can reduce the bulk of the uterus. We can do a good IVF outcome, as Dr. Meenu has explained very nicely, that how can we improve the IVF outcomes. So it's the story starts with good diagnosis, as Dr. Archana has explained. Because if we can pick up a disease, we can treat it nicely. And the concepts which are to be followed, they have to keep being updated. I would like to welcome the worthy experts with me, Dr. Anupma and Dr. Surbhi. Both of them are very close friends. And the interesting thing is that the moderator enjoys doing laparoscopic surgery, and my experts and most of my panelists, they're IVF leaders in the field. So let's see what the final comment comes on the management. I would like to welcome my expert panelists around. Dr. Shweta Nimonkar, can we have their slides? Otherwise, I know most of them. I can introduce them. Akriti, what is your suggestion?
Absolutely your call. Ma'am, they'll just brush in the slides, just like
Okay.
so that.
Yeah. Dr. Sangeeta Maheshwari, an excellent IVF specialist in Dehradun, and nowadays she's heading the OBGYN Society also. She's the secretary and she's doing very nice meetings. In fact, Dr. Archana, we would like to invite you to Dehradun for one of the live meetings. And then you can meet all our society members. And Sangeeta, you should organize a nice live conference with ma'am.
I would love to come. It is definitely due. And
Yeah.
Dehradun is a place where my mama lives. So, like, no want to come to physical meeting. So please organize one. And whenever there is one, just give me a call. I'll be there.
I would like to welcome my panelist, Dr. Richi from Kashipur, Dr. Kanika Chandra from Dehradun, Dr. Sangeeta, we can see. Rest of the panelists, I can't see them on screen. Dr. Shilpa Sharma, she's also an IVF specialist. Dr. Ruchika Garg, she's also running a private practice with IVF. Dr. Anushri, Dr. Anuja Nanda, and Dr. Shweta Nimonkar. So I'll start sharing my screen.
Ma'am, good evening. I'm here, ma'am. I've joined.
Okay, welcome, Shilpa. Welcome.
Thank you so much, ma'am.
So let me quickly join.
सुंदर सुंदर चेहरे दिखा दो भाई जो लोग ने नहीं दिखा रखे हैं.
हाँ, Anupma, बीच में we need lively comments by you. Okay. Is my screen visible?
Yes, it is visible.
Yeah.
Ma'am, please
So
be
as-
on the slideshow mode.
Slideshow ले लेना.
Thank you. Yeah.
Okay, 1 second. Yeah. Actually, my laptop is troubling. I think, आज hang हो गया because I have shut it down twice. So I'm not able to come to full screen. I'm
कोई
sorry.
बात नहीं. Let it be.
I just hope the slides are
Aarti, just go on the presentation. It is there on your screen. We can see, right? It's there, slideshow. Just
Yeah.
go there. It's
Yeah,
there
I
on
know
your
that,
screen.
ma'am. I
Top.
know that, but right now there is some problem with my set because when I click here, the full screen thing, it's not coming. That's my problem actually.
Okay,
I
okay.
just
Aarti,
hope
there is another way of going about it. एकदम टॉप पे जहां तुम्हारा कर्सर है अभी उसके जस्ट नीचे वाला
I
स्लाइड
know
शो
that green वाला अभी तो मेरा
नहीं
स्लाइड भी नहीं
नहीं
चल
नहीं
रहा है
ग्रीन वाला
अनुपमा।
नहीं
या
जहां टॉप पैनल लिखा हुआ है एआरटी पैनल एडिनोमायोसिस लिखा हुआ है वो सबसे ऊपर देखो एआरटी पैनल स्लाइड एडिनोमायोसिस एंडोमेट्रियोसिस लिखा हुआ है उसके ये इसके जस्ट नीचे देखो एक स्लाइड शो लिखा हुआ है ना
Ma'am, home,
थोड़ा सा बगल में
insert,
आओ उसके
design, transition, animation,
हाँ
and then
इसके बगल
slideshow.
में
या
देखो देखो
No,
ट्रांजिशन
at the top
एनिमेशन
पे
स्लाइड शो वहां पे जाओ
जहाँ पे होम का बटन है ना उसी लाइन में मैडम।
होम से राइट चलिए, होम से राइट चलिए।
See, I have been doing presentations, but today my system is troubling.
नहीं वो हम समझ गए बट एक बार यहाँ से ट्राई
प्रॉब्लम
कर
इज
लो
अभी तो मेरा स्लाइड मूव ही नहीं कर रहा है माय डियर गिव मी अ
चलो
मिनट बिकॉज़
स्लाइड 2 पे क्लिक करो।
माय
Can you
फर्स्ट
select
स्लाइड
your
इज
next
विजिबल
slide?
ना that's what I'm not able to move because today my laptop I don't know why it's troubling. I keep doing presentations with it. Yeah, so you can see my first slide, I believe, isn't it?
Yes.
Yes, ma'am.
Yeah.
केस प्रेजेंटेशन कैसे होंगे
फेस से ज्यादा तो ये जरूरी है माय दिस थिंग इज नॉट शिफ्टिंग टू अनदर वन स्टॉप शेयर सी आई विल स्टार्ट शेयरिंग अगेन देन ओके
ना उससे कुछ नहीं फर्क पड़ेगा आरती मुझे लगता है तुम्हें शट डाउन करके फिर से रीस्टार्ट करना पड़ेगा दैट इज द
Or
ओनली
else,
Ma'am,
can you
or else
please?
you can mail it
wait
to
wait
me.
wait no
Yeah,
just
Shruti.
wait just give me 1 minute
Chalo, in the meantime,
Now it's
we can
proper.
probably
Now it's
start the
proper.
start
discussion.
discussion
Now
because
it's proper. आप एक
it's
बार
proper,
try
but I'm
कीजिए ना.
not able to go to my second slide.
Click कीजिए एक बार.
I know that I have been doing it all my life, you know.
Yes.
COVID
Ma'am,
time.
or you can do one thing, either mail the PPT, I'll share from my screen.
Okay. The problem is with Apple na.
Hello.
So Anupma, you
Hello.
start discussion on the first case.
Yeah.
I'll
Please start.
read it out. The first case is a young girl who's 22 years and she gets severe pain every month, and the pain is so bad that she has to miss her college. And now, when she gets her ultrasound done, it shows a classic adenomyotic uterus, uh, where the posterior myometrium is double the thickness of anterior wall. And this girl wants relief from pain. So you start discussing this case. Meanwhile, I'll shut down the PowerPoint.
शट डाउन करके और पॉसिबल हो तो किसी को मेल कर लो पहले, उसके बाद शट डाउन करना.
Okay, all
if
right.
it's possible.
Okay. You start the discussion.
Okay. So, who all are there? Dr. Anuja, are you there?
Yeah. Yes, Dr. Anupma, I'm here.
Hi, Anuja.
Hi,
So
yes.
let's just start with this case. That it's a young girl, and she's come up with a severe dysmenorrhea. So what comes in your mind, and how would you go about it?
So once we see a young girl with severe dysmenorrhea, at her age, it is very important to do a few tests so that we get a DD, which is very, very common. We just talked about adenomyosis, endometriosis. It's also dysmenorrhea can be functional. There can be many causes. There can be no cause. So first of all, I'd order an ultrasound to make sure that she doesn't have a cause like adenomyosis or endometriosis for which we need treatment.
Well, Anuja, do you think that doing a transabdominal scan is okay, or doing a transvaginal scan gives us better sensitivity for endometriosis as well as adenomyosis?
Ma'am, definitely a TVS, but she's a young unmarried girl, 18-year-old. So we'll have to order a TAS.
Yes.
So
So this
can I?
was the point I wanted to highlight, that, we are going about with a transabdominal scan, and always a transabdominal scan is not the best investigation because the sensitivity is not as good. So
Can I?
sometimes, so
Yeah.
MRI is sometimes would be, if you're suspecting, then
Yeah,
MRI.
but we'll start with
Yes,
ultrasound first.
I agree. To
Yeah.
start with, you'll go with this only. I'm just highlighting one of
Yeah.
the points for a young girl. Yeah,
Yeah.
okay. Go ahead, please.
Yeah, so you want me to go ahead with this management? So if the ultrasound is suggestive of, like in this case, you've said that the ultrasound shows adenomyosis and a small endometrioma, right?
I don't remember. Yeah, probably there was an endometrioma too.
Yeah, I mean,
Okay. So,
hello, am I audible?
Yeah, you're audible. Okay, so now let's talk with Dr. Shilpa. She's also one of the panelists. Or maybe Anushri, who else is there?
Ma'am, I'm here.
Okay, hi Shilpa.
Good evening, ma'am. How are you doing?
I'm good, Shilpa. So maybe we can carry it further. How would you approach this patient?
So, ma'am, as told by Aarti ma'am, that the patient has a focal adenomyoma, I believe a small adenomyoma, or
It's the posterior wall was double the thickness of the anterior wall.
Okay.
So it looks like a diffuse posterior wall
diffuse.
adenomyosis.
Ma'am, because it's a diffuse adenomyoma, so because she's a young girl, she has a long life to go forward and she has a pain history. So we'll start with basics medication first and see how her response is to it. So we can start with basic NSAIDs for the starter. We can see if Meftal works for her. And if that does not work for her, then we may need to go ahead with oral contraceptive pills. Sometimes they also do work well for these kind of patients. And if that is also not working, then we can also go ahead and discuss whether she's comfortable with progesterone only pills. Apart from that, we can also suggest the newer drugs which are coming in. The Dynogest can be prescribe to her if the others are not working. Um, because she's an unmarried girl, otherwise the option of Mirena is also available to us. But sometimes unmarried girls who are not responding to the other medications are advised Mirena just because of the good relief that it gives them. Apart, if Mirena, and sometimes you just, because of Dynogest and everything, you cannot go on for a long time. So they have to keep shifting from treatment to treatment. And now the newer drug, Elagolix, is also available to us, so that we can also just suggest that for relief. Now, depending on the pain relief, we have to modulate the dose of the Elagolix, whether we are starting with 200 milligram, because it can be only given for 6 months, and then we have to drop it down to 150 milligram for 1.5 years. Now, depending on her progression, we have to see which drug we are starting it and shift to the other medication as and when required. Now, because she's a young girl, adenomyosis usually, as Meenu ma'am also told in her, spoke in her talk about, that it is usually also associated with the endometriosis. So we need to also see what her fertility index is like, how her antral follicle count is. And maybe in the while the process we are going through this, because I think we are fertility specialists, so we're so concerned about fertility. So we have to even counsel her regarding her fertility, because even though she's 22, so we have to talk about her future prospects, about her marriage, her freezing of the eggs, if that is required because of her antral follicle count, how her endometrium is like. So that also has to be taken into consideration.
But here I would like to raise one point that at 22, she must be sexually active, because adenomyosis in an unmarried girl without any history of miscarriage or anything is very unusual finding. So maybe we can switch over. If she gives a history of being sexually active, we can just put in IUS Mirena.
I would say Mirena just for that reason, but that would come as we speak to the patient.
Relieve her pain.
Yes, ma'am, I agree.
Yes, Dr. Surbi is right. Basically, what as Shilpa said, that LNG IUS is one of the options. So it is very important that these days, if there is a lady of 22 years, even if she's unmarried, it is always good to ask this history, that she's been sexually active or not. And if she's been sexually active, the first thing is that do a transvaginal scan first. So that is going to give you a better picture, and you will assess it better, that how much is the disease burden. I actually do not rely completely on the transabdominal findings for any aggressive treatment. All through everything else Shilpa has added, there is one point which in the management, one drug which I would actually want to give to this patient. So is there anyone else in the panelists who would want to give trial of one more drug before
Ma'am,
switching
Shweta
on
ma'am
to
is there. Dr. Sangeeta is there.
Yeah, hi Shweta. So maybe you can take
Yes,
it.
ma'am. Once you pointed out, I do think I missed the GnRH agonist. I'm so sorry.
No, it's okay. GnRH agonist for a young girl, how long am I going to give that? That was not what I'm looking for. Maybe Shweta is going to pick it up.
I just wanted to add one thing, ma'am, because since we were talking about LNG IUS, there are subdermal etonogestrel implants are available these days, coming with the name of Implanon. They also do the same thing. So basically, what we want is a hypothermopituitary ovarian axis suppression. We want to create a hypoestrogenic environment, and in those patients where those who are not sexually active, and we want to give an alternative of LNG IUS, implanons are another device which are available to us.
Okay, Dr. Anushri, are you there? आकृति और कौन है पैनलिस्ट्स में?
मैम संगीता मैम.
संगीता मैम, आप कुछ प्रकाश डालेंगे? Anything else which you want to add? Okay, so Aarti is probably
on my phone. Yeah. On my phone, my guys.
I just wanted to add one more thing, which probably I would go about in this patient, and that is giving letrozole. So letrozole is one drug which is an anti-estrogen. And for if you are actually looking for a long-term treatment in an unmarried girl, so adding letrozole for a long time and adding Metrogest along with that. So you are basically giving an the basic reason of adenomyosis is relative progesterone deficiency and relative estrogen excess. So you have to cut down on estrogen by giving letrozole for a long time, and you are adding progesterone by either giving LNG-IUS or giving Metrogest for a long term. So that is one medication which is easy to give rather than going for OCPs. This is a better medication. But of course, this is only for that unmarried patch of her life. Whenever she is she's sexually active and married and ready to have a baby, I would be very aggressive in telling their family to let her get her married as soon as possible, so that my concern is probably being an infertility specialist, I'm really scared of this very thick adenomyosis, that fertility would be an issue later on in the life. So that is one drug and if she's at all sexually active, along with letrozole, I would prefer giving her LNG-IUS. Why? Because as Shilpa said, that it's locally releasing, and it is the Metrogest side effects are in the pan body, but I want my effects mainly at the level of the estrogen. So my first choice would be personally giving letrozole for long term along with LNG-IUS. So, but I believe everybody else is also right. This is just various ways of going about with adenomyosis. In a young girl, I am insistent on doing a transvaginal scan or a MRI is that it is unusual to have, जैसे सुरभि ने बोला कि it is unusual to have a severe adenomyosis in very young girl. So it is better, it can be, but you should have very high, strong suspicion of ACUM, the accessory cavitary uterine malformation.
Yeah.
For that, I am insistent. And recently, last month only, I diagnosed one such, unmarried girl. I had ordered. I mean, lately, एक साल से मैंने advise करना शुरू किया. Not everybody gets it done, but एक बंदे ने कराया तो उसका निकल के भी आया. So it does come, So एक young girl में endometriosis मिले. बहुत यंग गर्ल से मेरा मतलब 14-15 साल पे अगर हमें सिवियर डिस्मेनोरिया मिल रहा है, आई जस्ट गॉट इट डन फॉर सिवियर डिस्मेनोरिया ओनली. सो बहुत यंग गर्ल में अगर सिवियर डिस्मेनोरिया मिल रहा है या फिर एंडोमेट्रियोसिस यूनिलैटरल मिल रही है, तो वी मस्ट सस्पेक्ट अबाउट ACUM और मुलेरियन एबनॉर्मैलिटी.
अभी कल मैं पढ़ रही थी तो अभी लेटेस्ट ट्रीटमेंट दो अभी इट इज अंडरवे in a young girl with severe dysmenorrhea with adenomyosis. We can do uterine artery embolization also. It reduces the size. कल मैंने पढ़ा था and H-ray अभी उस पे work कर रहा है.
My one question is, can't you add vaginal progesterone to reduce the things in a young girl?
Vaginal progesterone is as good as giving LNG-IUS.
Oral progesterone will have a pan body effect, but
yes. So that is why LNG-IUS is better rather than going for vaginal progesterone. It is releasing only 20 micrograms just in the uterus, whereas vaginal will get absorbed, and pan body distribution is little more than the
the parents will not agree for this. So
मैम अगर वजाइनल प्रोजेस्टेरॉन दे रहे हैं तो मे बी मेरीना भी, मुझे ऐसा लगता है मैम कि मेरीना की एक्सेप्टेबिलिटी का सबसे बड़ा प्रॉब्लम जो है वो गायनोकोलॉजिस्ट है रादर देन पेशेंट्स. सो पार्डन मी, मैं किसी को एक को भी एक्यूज नहीं कर रही हूँ, लेकिन मेरा ऑब्जर्वेशन यही है कि पेशेंट्स को मैं अगर 10 को बोलती हूँ तो 8 तैयार हो जाते हैं. इट इज हाउ अग्रेसिवली वी आर पुशिंग इट, एंड इट इज अ वेरी गुड ड्रग LNG-IUS.
वेरी गुड. मेरी तो 5 पेशेंट्स जो कि मेडिकल की वो ले रही कोचिंग कोटा में, यंग गर्ल्स अनमैरिड, सब मेरीना लगा के गए हैं.
इसका वॉल्यूम लो कर दो.
Dr. Anupama, I have a question.
Yes, Anuja.
Yeah, so I wanted to ask that I read somewhere that letrozole can be used along with a progestin can be used for a maximum of 6 months, considering that she's an unmarried girl and she has a long way to go. So, would you be comfortable giving her letrozole, norethindrone, or medroxyprogesterone combination for years, like 2, 3, 4 years? Wouldn't it be better to put her on a Dynogest ethinyl estradiol, OCP, or
Anuja,
something like that?
I'll answer that. Anuja,
Yeah.
basically, it is the estrogen excess which is the culprit. Okay. So instead of giving ethinyl estradiol and progesterone combination, we should cut down on estrogen. I agree with you that on long term there will be problems with osteopenia and stuff. But if you are giving GnRH agonist or oral antagonist, elagolix is going to come big way in future, in such a patient. So elagolix also is the answer. Agonist is also the answer. In सब में 6 महीने से ज्यादा तो बिल्कुल नहीं दे सकते हैं. Letrozole is not that stronger effect as compared to agonist. अगर तुम रेट करोगे इन तीनों को तो agonist का सबसे अच्छा इफेक्ट है. तो अगर मुझे इस एडनोमायोसिस वाले पेशेंट में एम्ब्रियो ट्रांसफर करना है तो मैं agonist दूंगी. फिर उसके बाद में मैं एंटागोनिस्ट दूंगी और फिर थर्ड नंबर पे ये लेट्रोजोल का ट्रीटमेंट आएगा. लेकिन जब यहाँ पर कंसर्न जो है वो लॉन्ग टर्म है तो इट इज द अदर वे अराउंड. या
Speaking like a true fertility specialist, like
दिल से वही निकलता है.
Thank you, Anupma. My guy is setting it up. So now the choices we have are starting from the basic ones, combined oral contraceptive pills, the most commonly used. The pills can be used either 21 days and then we give a gap, or we can use them continuously for 6 cycles. They are easily available. Even in an unmarried girl, the mother may accept it with a doubt or with a pinch of salt that why the doctor is giving my daughter hormones. The first step is very, very difficult to make them understand that the disease will only get controlled with hormones, not with any alternative therapy. Even the ESHRE guidelines say that COCs should be given and there are strong recommendations. For an unmarried girl, again, the second choice, there are a lot of studies, as Anuja is also saying, letrozole because it is anti-estrogenic along with a progesterone supplementation. Okay. It also gives good result, but we can give it up to 6 months. Why ESHRE does not recommend GnRH agonist or antagonist for long term? Because one has to be clear that we have to give ADVEC therapy to these young girls if we put them on agonist or antagonist, because in long run they play badly on the bone mineral density. And then if the adenomyoma is like the posterior myometrium is doubled up, and if the girl is not too keen to take medical treatment, a good surgery may also help in reducing the volume, followed by maintenance therapy by medical treatment. Now, coming to Mirena. Mirena is a very good device, but few of my patients whose uterus was enlarged and who were passing clots, within 2 cycles, some of them, they came back with Mirena with a clot. Yes, ki ma'am, it has come out. So whenever I put Mirena for adenomyosis, if the cavity is large, like 9.5, 10 centimeters, I always tell my patient, see, I have put it near the fundus, but if you will bleed heavy, because 1 or 2 cycles, you may give them progesterones along with that, it may come out. So the counseling plays a great, great role for these patients, for which, the disease is chronic. They'll keep coming back to us. And of course, once she gets married, we have to give them fertility also. So the dilemma, counseling, choice of clinicians, preference for different drugs, everything will matter in it. Because even if you check ESHRE guidelines, there are strong recommendations for pills and hormones, and then weak recommendations for agonist and antagonist in young girls. But of course, as suggested by you, whenever it comes to fertility, we have to reduce the size of the uterus. They give us remarkable results. Yeah. So the second patient which I had, although I'm sorry, this guy is, on it. My second patient is a 28 years old woman. She has one daughter who's 5 years old, and now she comes to us with pain in abdomen during periods, which is very bad. And on ultrasound, the ultrasound shows adenomyotic uterus with two endometriotic cysts. One is 6 centimeters and another one is about 8 centimeters, and they are kissing ovaries. And on ultrasound, you can see that the cyst wall is stuck to the posterior surface of uterus, and the movement of ovaries is very limited. So how do we plan her treatment? Like, how will we recommend that can we offer her medical treatment, or we tell her, no, because though your cysts are very large, so go for direct surgery? I would like to take Dr. Oli's opinion first, because he has not given us a word. And I'm so sorry, because I had collected very good videos and lots of images, and my laptop is stuck now. I'm feeling bad because I had a lot of interesting videos also. Yes, sir. Sir, you are muted. Sir, you have to unmute yourself. क्या हो गया भैया?
सर अभी हुआ नहीं आपका अनम्यूट.
Upinder sir, I've sent you the request for unmuting yourself. Please unmute yourself. Yeah. Now it's fine, sir.
Hello, ma'am.
Hi, sir. Hello.
I'm audible?
Yes, sir.
Yes, madam. You have already told about all the modalities and treatment plan for the endometriosis in young girls as well as in fertile women. So I don't think anything is remaining. Thank you.
Dr. Kanika, how would you like to manage this 26 years old lady who's para 1, and her main problem is severe pain during periods, and her ultrasound shows 2 large endometriotic cysts stuck posteriorly, and the size is 6.5 and about 6 centimeters?
Yes, ma'am. Good evening, ma'am. Okay, so when the patient is already having severe dysmenorrhea and she has a large cyst of approximately 8 centimeter in one side, which is left ovary, and one is 6 to 6.5 centimeter. So we can actually counsel the patient for surgical modality, surgical intervention, so that the endometriomas get drained out and the cyst wall should be removed along with it, and patient get relieved. And even after the surgery, we should put them on Dynogest or any progesterone, so that would be helpful, and there'll be further reduction in the adenomyosis. And we can also go for Mirena intrauterine device too.
Absolutely. So for large endometriotic cyst, surgery should be the first option.
Yes.
But what is your opinion about the pre-operative medical therapy for this lady? If she says, "No, doctor, my daughter is having exams, so come 4 or 5 months, I will not come to you for surgery," then how will you counsel her, or how will you manage her with medical treatment if she's not too keen for surgery right now?
So, ma'am, we can start with...
suggest, yeah.
Ma'am, yes. So if the patient wants to buy some time, we definitely can offer the medical treatment to her. The first line treatment always remain a continuous COC in her case, because that will address to her pain also. And the long term, a single time, any medical management we want to give, we can give her like Leprozoid, GnRH agonist as a second line treatment, and even GnRH antagonist will also work good for her.
But we want to know whether she wants to get pregnant or not. That's the point. If she wants to get pregnant, then we should take up.
Yeah, she's for surgery, but
done
I just want to understand if the patient wants to buy some time because she's, not mentally prepared for surgery. How many of us believe in giving pre-operative GnRH agonists to control the disease?
Can you take this, ma'am?
Yes, we can.
Yeah, Dr. Ruchika. Yeah.
Good evening, ma'am. Ma'am, GNS agonist should always be the second line of treatment as it leads to adherence of the capsule of the cyst, and it will make the surgery even more difficult. If the patient is planning surgery in the near 6 months, Dynogest or combined ocipils, continuous combined ocipils should be a first line of treatment. Both antagonists, elagolix as well as GnRH analog should always be the second line if the patient is progressing or postponing the surgery more. And the best option is that the surgery should be done followed by IUCD, levonorgestrel IUCD should be inserted if the fertility is not to be planned in near future.
Thank you. May I ask our expert, Dr. Anupma, to give her views on this case now?
So there is one option that in this patient who's not planning for surgery very soon, firstly, I would, rather than telling her to take pills, I would push her to plan a pregnancy and check her fertility potential because she still has a 2-3 months window. As Dr. Sudbi said that, in future, once the surgery is done, there will be an impact on her ovarian reserve as well. So because of that impacted ovarian reserve, her chances of fertility will also be affected. Considering that, I would want her to plan pregnancy if at all she wants that. So supposing she's completed her family, she's not wanting any babies further, that's a different story. Then in that case, I think giving Dynogest for long term would be a better treatment option, or else we can give oral antagonist also, elagolix also for long term. I personally, since I am doing sclerotherapy very routinely, so I personally also go for sclerotherapy treatment. But actually, this endometrioma is a very large one, 6 centimeter and 8 centimeter probably. For this bigger size, sclerotherapies and all would not do wonders. The best thing is till 2, 3, 4 centimeter, even sclerotherapy is a very good treatment. Sclerotherapy is nothing but you just take out the content and instill alcohol to burn out the wall of the cyst. So that way it is a locally effective mini invasive treatment, you can say. It is also an effective reality.
Sometimes we can also use this after aspiration, we can give injection of methotrexate in the cyst.
Now the Pandora's box is open, Anupma.
No, methotrexate, I don't
we
think,
can't
but,
give because it will
Yeah.
cause
when
I
you
was
are
just follicle.
puncturing the endometriotic cyst at all, it is a very potential side. When we are doing pickups, there is a chance that we can puncture the endometrioma. We try to avoid, but sometimes we do puncture. So in that case, it is a very valid risk of getting a very bad abscess in the pelvis. So we should avoid at all cost puncturing the endometriomas. Why? Because it's full of blood. And blood is nothing but a good culture media for all the bacteria, right? So we should try avoid. That is why doing surgery is a better option. Because
Anupma, sorry. I wanted to ask you, how do you use sclerotherapy? Do you go laparoscopically or you do it ultrasound guided transabdominal or transvaginal? What is the exact procedure which you use?
we are
Ma'am,
doing
even I have a question on sclerotherapy. Like ma'am said that it can be done, but still I think a number of studies are against sclerotherapy. I had used it before when I started doing IVF. I used it for like first or 2 initial years, but then after I abandoned it because
So
pre-IVF.
how do you it? Because say I know Pratibha Saini ma'am will also share her views. I have seen a lot of patients being handled by ma'am. So actually this is a real controversy and we should make it clear because we don't want that our delegates, they start trying it and their patients land up in
Yes.
complications,
That
and
is the
there
point
are
which I
pelvic
wanted to raise, that pelvic
abscesses,
abscess
and
is one
yes,
valid thing
so
which
you
should be
have to
kept in mind.
explain it, and we want to know Pratibha Saini ma'am's experience also on
मैम
this.
बताएं, मैम की सुनते हैं.
Yes.
Well, with ovarian endometrioma, I did a lot of local transvaginal puncture with the IVF needles. And very frankly speaking, under full aseptic condition, touch wood, there was no case of abscess. IVF output have increased, the oocyte quality have improved. So with the big endometrioma, because endometrioma, patients generally come to me with one laparoscopic removal, the second one has come, the third one has come. For they have gone for 4 or 5 laparoscopic surgeries for ovarian endometriomas. So I only did the puncture, and after that, in the local, I use hyaluronidase so that it should degenerate the endometrial lining. And I put the antibiotic inside it. That's all.
What antibiotic, ma'am? And
so, which is available like I did with gentamicin, generally gentamicin or amikacin.
Okay, so मैम के पास में भी एक पक्ष है बताने का कि what alcohol is doing is it is an antiseptic, you can say, and as well as because of the presence of the alcohol, the chances of infection are not there. Secondly, because of the alcohol, it also burns on the lining. So similar thing is happening. But you know, as Akriti said, that you should not expect that it is 100% effective. I have been lucky. Most of my patients, I would not say 100% of my patients, but in most of my patients, the recurrence had not happened at that particular. Say, supposing there are 6 small endometriomas, and I have instilled in 4 of them, and 2 are left. The small ones would be left. They will come up in the near future. That is what the problem with the surgery is. You know, once you remove the surgery, but whatever small is left over there, that will come up because the disease process is there in the patient's body. So leave everything aside. Sclerotherapy is to be done only for a person who is trained to do it. Surgery, even surgery, more important is I am not very good at the endometriotic laparoscopic surgeries. So probably that is the reason why sclerotherapy is a chosen alternative by me. But if you are very good at surgery and you can remove the mass completely, the cyst wall completely, there's a lot of adhesions, adherence, and it has been documented that after first surgery has to be the best surgery, and try not to do a repeat surgery on a patient because that will really kill her ovarian reserve.
I would like to add. Yes,
because once you get one endometrioma, by the time if she is not pregnant, the second or third endometrioma, again surgery, again ablation. So I think sclerotherapy has a role, but it should be done in a very strict aseptic condition to preserve the ovarian reserve. Because there are patients where we got the minimal ovarian tissue left.
As Aarti said, you know, ये सर्जन और infertility specialist का झगड़ा ये चलता रहेगा. But इतने बड़े endometrioma में मुझे कोई शक नहीं है कि 8 सेंटीमीटर में मुझे तो सर्जरी करनी है.
Yeah, for this patient, of course, surgery, but at the same time, sometimes at the time of surgery, again, there are controversies because to have good ovarian reserve, to have better AMH levels, we have 3 options. Number 1 is we do the surgery, we remove the capsule of the cyst, and we completely remove the disease and leave the ovary. Number 2 is people will do cyst aspiration and irrigation, and they'll say the cyst is cleared, which may come up again because if the cyst wall is there, it will come up again within few weeks only. Number 3, if the patient has poor ovarian reserve and if she has undergone 1 or 2 sittings of surgery, and if endometrioma recurs, then that is the indication when sclerotherapy can be done because we are not using thermal energy. But at the same time, I believe this chemical effect on the basic antral follicles will also cause a slight fall in the AMH. So that's why the moment she said sclerotherapy, I said it's Pandora's box. I have my reservations for it because I feel now the laparoscopy has become so convenient. The cameras are so nice. You can see even the smallest of lesion very clearly. The tissue sealing devices and the energy devices are so fine. You don't use very big those bipolar clamps to stop bleeding the way we used to do it earlier on a poor resolution cameras. If the resolution is very fine, you can just coagulate the bleeders to the minutest point. So that way you save lot of ovarian tissue and you can give a better ovarian reserve. But of course, the controversy will carry on. Bigger says we have to do surgery, sclerotherapy only by masters like Anupma has been doing it. She's very good at it. Pratibha Seni ma'am has been doing it. But I will strongly suggest, please don't try it, because I have seen one patient who had undergone cyst aspiration somewhere. She had pelvic abscess. She was admitted at AIMS Delhi for a few months because the pelvic abscess was very bad and she had 3-4 drain punctures and everything. So the patient may get better, but sometimes the complications can be very bad for the patient. I'm sure Dr. Sangeeta will also agree. If you have tried it, what is your experience?
Aarti, every surgery has.
I haven't tried, ma'am.
Yes, ma'am.
Good
But this
experts
is something which is experimental.
maximum aseptic conditions. I think this gives us a good alternative just to preserve the ovarian reserve.
Absolutely, ma'am.
One has to see the parity. If the patient is nulli para and she wants to have a pregnancy, then these can be tried. Otherwise, surgery is the best answer.
I think Aarti has disconnected.
Yes, ma'am.
So संगीता की बातें सुन लेते हैं.
Ma'am, I would never
I'm
try
trying to
something which
yeah.
is not not recommended by guidelines, because we are living in an age of medical legal cases. So when we are not trained for that and we have never tried, I would not recommend this. You had been doing it.
Since you're talking about guidelines, so I also wanted to highlight this, that it has been suggested in the guidelines that repeat surgeries for endometriosis are to be avoided, and first surgery of the patient should be
the best,
from very good hands, and the best surgery. Yeah, we have to be aggressive there.
Yes.
Okay, so I think we should, Aarti, move on to the next.
Yeah. So, Anupma, because Dr. Ashna, I'm so sorry, but there are so many controversial things. Anupma, now I want to understand, there are lots of studies on microwave ablation for adenomyosis. Number one, what are your views on microwave ablation? Or
never used it, so no opinion.
HIFU. A lot of people are advertising about HIFU. Few centers are doing it. So, is any of the experts sitting here, do you have any experience with HIFU or microwave ablation? Any of your cases? Sometimes you get a patient that I got it done from there and now.
I wanted to say something, not about HIFU. Basically, what is happening in adenomyosis is that there are invaginations of the endometrium happening within the myometrium, right? So that invaginated endometrial tissue in the myometrium is responded by the healthy uterus. The healthy myometrium gives a hyperplastic area, hypertrophied smooth muscles around those endometrial deposits, right? So what is happening is that hypertrophied area which is come up isn't as well functioning smooth muscle tissue as the original one is. So ultimately, what is the use of that smooth muscle of the myometrium? The purpose of that smooth muscle is to give a tamponade effect on those the vessels which are passing through the myometrium. When the uterus contracts, it clamps up those vessels. So when there is adenomyosis, that clamping thing is not happening perfectly. And that is the reason why the excessive bleeding is happening in the patients of adenomyosis, right? So ultimately, when we are targeting a treatment modality, it has to be around the basic pathophysiology is to be corrected. So probably this HIFU is going to ablate some of the tissues. If we are doing adenomyomectomy, again, we are just reducing the disease burden. You know, adenomyomectomy is a very valid treatment for huge adenomyomas. You know, that is the treatment. So ultimately, we have to reduce the disease burden on the uterus, which is making it irritable. So these are all the various ways. You know, medical management is just for those small ones, you know. But ultimately, अगर बड़ा adenomyoma है, एक 12 वीक्स का 20 वीक्स का यूट्रस हुआ है, तो उसमें कोई भी मेडिकल ट्रीटमेंट क्या ही करेगा. अल्टीमेटली सर्जिकल ट्रीटमेंट इज देयर. एंड हाइफू जो है, वो मुझे अगेन वही लगता है कि वो भी मेडिकल ट्रीटमेंट का ही एक वेरिएंट होना चाहिए, और ह्यूज उसमें तो वो भी नहीं इफेक्टिव होगा.
So I have one more question now because most of the people are IVF masters here. You know, a large uterus, say around 8 weeks, with marked myohyperplasia, okay, and the typical Venetian blind appearance. If the patient wants IVF because she's not getting pregnant naturally and she's about 36 years, would you recommend a surgery if GnRH agonist cycle has failed twice? Or would you recommend surrogacy? Because recently I saw a patient, adenomyotic, previous 3-4 failed IVF cycles. And now she comes to me, ma'am, can you please suggest from where do I get a surrogate? Because now my doctor says 4 failed IVF, you go for a surrogate. So how do you guys manage these cases?
If somebody else would want to say something, maybe then I'll share my experience.
Can I answer this?
And at the same time, sorry, मैंने slides श्रुति को mail कर दी हैं. I hope she can share. Yeah.
Now this
So,
patient,
Aarti?
say suppose she comes to me. Now she
Yes,
has
ma'am.
already had 4 IVF failures. It's very difficult to get a surrogate. Seeing her all parameters. Now we see the embryo quality. If you are getting a good embryo, you go for the frozen cycle and then give a long protocol GnRH and agonist to her, so that the disease is limited and the result, definitely she will get a result.
Can I put in a word, Aarti, here?
Yeah, sure.
Yeah, you know, like these are the very challenging cases where there are
Yes,
4
ma'am.
failed IVF, adenomyosis, but still we should not lose hopes, right? There are different modalities with us. I think all of us have spoken about Endogolix and Myrina. Maybe you can keep her embryos preserved with you and try and prepare the uterus a little bit more better by reducing the disease burden of the adenomyosis, either by giving her a 3 months of Endogolix, or maybe put in a Myrina and reduce the burden, and then try it. Because as Dr. Pratibha has said, that difficult to get surrogacy, and may not, though the patient has come herself for surrogacy, but still, as long as she has a uterus and you can make a good endometrial lining by reducing this, I think you can give a try for another cycle of IVF. I would do that in my practice.
Can I add a word, ma'am?
Yes, please. Yeah.
We can also go for adenomyomectomy and give a post treatment of with GnRS agonist. Once it starts reducing in size post surgery, then we can start preparing the endometrium and go for frozen embryo transfer also.
I mean, we all are thinking along the same line, that conserve the uterus and give her a try, because there is always light at the end of the tunnel. We cannot be just giving up. You know, I mean, even when there is a nature even is not giving you 100%. As a IVF practitioner, we cannot give 100%, but at least we can try and give them another chance. There is always another chance.
Ma'am, I think she's a good candidate for what Anupama ma'am was suggesting previously. She's a good candidate for Mirena with letrozole. We can see how her disease burden decreases. We have seen Mirena being instilled for 3 to 4 months for the disease burden being reduced, and then see whether, her uterus is preparing well with estrogen later when the Mirena is removed. Now, if this patient does not improve with Mirena, yes, Ruchika's option is there. We can plan with adenomyectomy with someone who is very skilled to do it. And then we need to see and see how her uterus actually comes up after the surgery. What is the remnant wall that is there and how her lining forms after that. Give her one good more trial of FET then. And if that doesn't work, yes, this patient should go forward with surrogacy at that point of time. But if Mirena and adenomyectomy has not been tried, then that can be given as an option before we proceed, ma'am.
I mean, nowadays microablation is also getting place. I mean, we recently had in IAG Bhopal, we had this microablation workshop, hands-on also we did in that. So I think there are positive signs and positive things about microablation, though not many people are doing, not many places equipment is available, but sooner or later, I mean, that's how the things come when more people will start using it and the more results will be available to us. So that will also become a good option
How
for
much reduction do
everyone.
they suggest, Archana ma'am? In the
I
body?
I will tell you. Microwave ablation, number one, it's an expensive technique. Number two, there are definitive indications. Actually, I had slides for all these, but I think I added too many videos and everything. So my PowerPoint is badly stuck. So if there is generalized adenomyosis, then the guidelines say microwave ablation will help. Number two, it does not help on a focal adenomyoma. Number three, if the adenomyotic tissue is more towards the serosal aspect of the uterine cavity, again, microwave ablation will not give very good results. And the person has to be very careful. It has to be done ultrasound guided. The person has to be little away from the endometrial lining to avoid thermal damage being done to the endometrial lining. And number four, I should not be saying, but the way people are showing that they did microwave ablation and the tissue is contracted, it has decreased. It takes minimal 8 weeks for the reduction in the volume of adenomyotic uterus or fibroid to occur. So for sclerotherapy, because I had slides and cases for both and microwave ablation, there are limited indications. Only then these methods will help us in getting a good outcome. So I had kept one more case. Uh, there is a previous cesarean patient. Yeah, videos delete karte de do. And then she has 3-4 small boil-like lesions at her previous scar site, and which have been oozing during periods. She has been going to different doctors. She has taken Dynogest for 6 months. Someone else has tried COCs. So what is the opinion of all the experts sitting here? Do you think if we have this kind of scar endometriosis cases, do you think we should be putting them on medical treatment, or is medical treatment effective for these cases of scar endometriosis, be it here, be it at the scar of previous C-section in the uterus? Dr. Surbi, you have to unmute yourself. I'm feeling bad for all the images because these were all good cases which we had done. Yeah. Dr. Surbi, unmute yourself, please.
Arti, such cases are clearly for surgical indications. Versus, when scar endometriosis, patient is seeing it. When the disease is inside, you are seeing it by ultrasound and you are diagnosing it. But if it is something which is oozing during her menstruation, it warrants a surgical excision.
Only treatment is wide local excision.
Yes,
I have done
that's
it in many cases, and sometimes till the sheath, till the rectus sheath, the lesion is there. So you have to put a mesh also. And
that's a clear
that's the only
message.
treatment.
Yeah, it has to be a liberal wide excision, so that, one patient, we had to excise the whole scar and till the rectus sheath because there were infiltrations in the sheath also. So we had to cut the sheath also, and then we had to put a wide mesh about 6 inches by 4 inches, and that patient is doing perfectly fine. So a liberal excision of endometriotic tissue and a mesh if needed. That's the correct treatment for these patients.
Sometimes, Dr. Aarti, it doesn't ooze, but the patient complains of pain at stitch site. And she's been running from one gynae to another. She's given treatment for PID, for several things. But during menstruation, if you get an ultrasound done, they will mark it that this is the area. And this is how we did on one patient. They don't ooze too much, but they just complain of pain at a particular site during periods.
Absolutely. So recently I saw a patient, this patient, she had irregular cycles, and she's also previous section. And there is a focal adenomyoma at the previous scar, but the tissue consistency, the hypoechoic shadows are like endometriotic cyst. So the radiologist had reported scar endometrioma. So I called him and I told him कि sir uterus में endometrioma नहीं आएगा. So this is a scar adenomyoma which is there. So what would you suggest for this patient? She's 41 years old and she has a big mass of about 4 by 5 centimeters. The way you see scar ectopic, thinning of myometrium, it's hardly 4 millimeters, and there's a big collection of tissue inside.
It could be isthmocele. It could be isthmocele also in the differential diagnosis, and it also requires the same either laparoscopic
surgical intervention.
First, we diagnose with hysteroscopy. If that isthmocele pouch is where, last month only we did it, last week rather. And then you do it laparoscopically, you open the whole stitch line and then you re-suture it.
Absolutely.
But I have seen one scar endometriosis. That patient is a very good friend of mine, not delivered by me incidentally in Chandigarh. She had episiotomy site for endometriosis.
That we have seen, yeah. So at the same time, Dr. Shweta, can you give few tips to the audience how to avoid these cases of scar endometriosis at the cesarean section scar endometriosis at the episiotomy scar, how the residents and other people should avoid happening?
So, ma'am, basically it is the endometrial cells which are implanted outside, and somehow they have escaped the immune-mediated apoptosis or cell death. That's why they are growing there. And the methods by which probably we can try to prevent it, probably by not using the same suture which we are using while closing the uterus in the rectus sheath or rectus muscles. And then probably if we are trying to, bury the incision line so that it is not coming in direct touch with the peritoneum and other layers. If we are closing the parietal peritoneums, probably if we are changing our gloves and trying to avoid any kind of contamination of uterine cells with other tissues, probably these things can help.
Absolutely. And the mops also. When we were doing PG, one mop used to be for the skin, another mop used to be for the cavity. And similarly, we have to be very careful when the baby is out. Those tiny endometriotic things, which some people will just keep putting it here and there. I make sure that it goes to the kidney tray, which is on the trolley. I don't leave it in the nearby area because those small endometrial tissues, if you leave them near the skin or muscle, that may lead to scar endometriomas later. Anupma wants to tell us something interesting. I know that.
Not really.
Yeah, I mean, something like this, which you have seen.
Thoroughly watch the surgical site. When you are closing, you just put
I
some
clean it with
betadine on the...
betadine, yeah, and remove all the tiny specks. Yeah.
I personally feel that scar endometriosis जिसको होती है, सर्जन सारे ही विजिलेंट ही होते हैं. कोई भी नहीं चाहेगा कि उसकी पेशेंट को ये हो जाए, और रैंडमली किसी को भी हो जाता है. एंडोमेट्रोटिक टेंडेंसी का कुछ पता नहीं लगता है. So it's a very good idea to keep all those small tips in your mind कि जब आप सर्जरी कर रहे हैं तो भैया कुछ भी एंडोमेट्रियल टिश्यू आप, but having said that, 100% रिमूवल कोई भी करता होगा, मैं तो मान ही नहीं सकती हूँ, क्योंकि आप जब उस ब्लड वाली फील्ड में हो, कहीं ना कहीं कुछ ना कुछ सेल एस्केप करती होंगी। पेशेंट्स की इम्यूनिटी है जो उससे डील करती है ultimately.
Pratibha ma'am, we need your comments.
Now, like after cesarean, when you put the uterus inside, we can do a good saline wash also. So that any deposit is there in the abdomen, that is going to be sucked out to prevent all these endometriosis deposits after the surgery.
Absolutely. Yeah, that's also good. Yeah. I think we'll do one physical panel when Dr. Archana comes to Dehradun, and then I can show all the videos and everything. So, Akriti, let us know whenever you want to finish. One more thing, one interesting thing I wanted to ask from the house. What is your opinion about CA125? Dr. Anuja must be seeing patients every other day, endometriotic cyst, CA125, 120. Patient कह रही है, ma'am, cancer हो जाएगा. So how do you counsel these patients? Number one. And then I want to know the opinion of the house that is there any association between endometriomas and malignancy? These two things we should clarify for our delegates. Thank you.
May I say something, ma'am?
Sure. Yeah.
So overall, the risk of malignancy is not increased. But then if you compare for specific malignancies, the risk of ovarian malignancy definitely is more than the other population of females by about 1.5%. The other cancers which are common are of breast and thyroid. So overall, the risk of malignancy is not much, but at least whatever the risk should be explained to the patient. And CA125 is never a diagnostic marker, but definitely a prognostic marker.
Absolutely. Basically, CA125 just tells us about the inflammation. So we have to clarify to the patients that higher CA125 does not mean that you're going to have malignancy, because there are lots of benign reasons for high CA125 also, and it is not a specific marker for the ovaries. So that's very, very clear. And Dr. Shweta has very nicely explained that there may be associated risk of endometrioid carcinoma, clear cell carcinoma, and some other cancers like breast and colon. So now any important point?
One point I wanted to add here, that ultimately CA125, if it is raised in a patient of endometriosis, you will not find high CA125 in all endometriosis patients. Sometimes a very large endometrioma and still her CA125 is absolutely normal, and sometimes it's vice versa. So it's ultimately the peritoneal coelomic thing which is producing CA125. So if the infiltration is there in the peritoneum, then only the CA125 would be increased. So along with endometrioma, if there are seedlings, then only we expect CA125 is there, raised CA125 is there.
Yeah.
That the same thing is happening in the cases of malignancies also.
So we can quickly have one expert tips from both the experts, starting first with Sani ma'am, quickly how to manage adenomyosis. And now can someone tell us, nowadays people are talking about diet in adenomyosis, diet in endometriosis. How many of you believe in that? Yoga for endometriosis. This is something very interesting which the patient would say. The patient will not say, Madam, treatment kya karoge? Madam, diet bata dijiye. So a quick opinion from everyone on that also.
I think
Ma'am batayenge. Yeah.
diet has a role. You see, whatever a healthy diet you take,
yes, ma'am,
to your body, definitely to your body. Again, I'm saying, please add turmeric and see the results.
Yes, ma'am. But ma'am, India में तो हम इतना turmeric वैसे खाते हैं,
लेकिन हम
although cooked खाते हैं.
कुक्ड खाते हैं.
Yes, I
और
believe.
दाल सब्जी में उतने मसाले के साथ खाते हैं कि उसका जो परक्यूर अच्छा, जो हल्दी मार्केट में आती है बेसिकली,
वो तो
बेसिकली
वो contaminated है.
रॉ हल्दी जो होती है ना, वो उबाली जाती है, उबाल के सुखा के तब बनाई जाती है, तो उसके कर्क्यूमिन लेवल बिल्कुल गिर जाता है. It should be a kachi haldi जो dry करके उसका powder. That is the main haldi for these
But
also.
ma'am, usko like what we do, we make उसको कहते हैं ना curcumin latte. आजकल Starbucks पे बहुत मिलता है US में.
Latte
Curcumin latte कि हल्दी वाला दूध है, but उसको भी तो boil करके ही पीते हैं. Then once you boil it, the curcumin content goes down.
आरती एक्चुअली हल्दी वाला दूध बनता कैसे है? पहले दूध बॉईल किया जाता है. जब दूध बॉयल हो जाता है उसके बाद हल्दी डाली जाती है. अगर आपने हल्दी डाल के दूध बॉईल कर दिया तो फिर आप वहीं पहुंच गए.
Yeah, that's what Starbucks does.
हाँ,
But it
yes.
sells like anything. About $14 का देता है वो.
हाँ, तो वो जो है ना, जब आपको उसकी नॉलेज नहीं है, because somebody told me, हमारी प्रीवियस जो फार्मर्स हैं वो सब हल्दी बॉईल करके पिसवाते हैं जो मार्केट में आती है.
Okay.
But for the medicinal value, it should be a raw haldi which should be dried and then make the powder and use it.
Thank you. Now we should give over to Dr. Archana. Dr. Archana, I'm sorry, my presentation did not play, but I think
But we had a very good
Anupma took the baton and she started a very nice discussion. Thanks, Anupma, for always being our perfect representative from Uttarakhand.
I think what has happened, Aarti, even if the presentation didn't work, the discussion was excellent. Because if there is a presentation on, people will not focus on discussion.
I just put the videos.
So
I had just put the videos and it got so heavy, my PowerPoint got stuck. Yeah.
But it was really brilliant. I think Anupama did great job, and all the panelists. I think they were so much engaged in the discussion because it's a everyday affair, right?
Yeah.
And everybody wants to take the tips from each other to help their practice and to help our patients to do the better. So I think
Sani ma'am, I must tell you, Dr. Archana, Dr. Sani ma'am, she doesn't come to too many webinars and she doesn't attend meetings because she has always been very busy being the first one to start IVF, and we are all very lucky that we had ma'am with us all through. Yeah.
I'm blessed.
He has been attending ASHRAE. Ma'am, आप बताइए, for how many years you have attended ASHRAE regularly?
I'm regularly attending ASHRAE since 1995.
Imagine how many years. Yeah, people attend for 1 or 2 years, then they say research बहुत है वहाँ पर, isn't it? Yeah. So अभी भी ma'am you are going every year?
Yes, I go.
Okay.
But, let me inform you, because we have gone into the hospitality business, and my Lee Meridian Resorts and Spa is coming soon in Dehradun, most probably in October. Then I will organize my meeting there with you all people.
Yes, ma'am. ASHRAE in India, that will be so good. International meetings like AGL happens in India now, and we get all the foreign faculty. They're very happy coming here.
Yeah, doing the very good work. But they say, no, we are only good. Then I say to them, look, we are also working hard. We get so many patients every day. Every clinic sees so many patients. Technically, we are best in exposure with the patient.
Absolutely.
Knowledge is
We
very
don't
good.
do reporting, otherwise we get the most infrequent cases.
One more generation और सारी publications देख लेना, सिर्फ 20-25 साल रुक जाओ, सारी publications जो है ना, ये नई generation जब आ रही है ना, इतना publications पे है, नए नए बच्चे अभी पैदा होते हैं, फर्स्ट ईयर सेकंड ईयर MBBS से इनको publication का pressure शुरू हो जाता है. जब ये वाले हम लोगों ने कभी किए नहीं ना, ये डेटा कलेक्शन और publications करना.
हमारे पास इम्पोर्टेंस नहीं पता थी कि ये पब्लिकेशन की इम्पोर्टेंस क्या है. क्या आप रोज की एक्सपीरियंस करते? When I was in Bonn, every day my professor used to ask me, show me your data. There I was lacking. Then I came to know the importance. So he only recommended me, make 5 or 6 files. Whatever cases you see new or whatever new finding, write down. Make it a data and present it. That's how I got into this business.
Perfect.
What Anupama is saying makes sense, because this new generation has got gadgets also. They are armed with the electronic media. We had to do everything with the paper, pen. And so then we had so much of workload with the patient, then doing that paperwork. Nowadays, with just click, they will do the Excel sheet, and then they can register everything on there. So that's an advantage. Plus, yes, they are at an advantageous position. Plus, they are focused. They want to do research. We have learned the importance of research and reporting our data, because that makes it more authentic and like, okay, evidence based. So I think all
मैंने
in all,
मैम
it was
अपने
an
बेटे को
excellent webinar
3
and was
महीने में,
excellent connecting with you all. Yes, Anupama, yeah.
नहीं बस मैं एक बात कह रही थी कि मैंने अपने बेटे को कैसे ये बात समझी, उसने 3 महीने में 20 पब्लिकेशंस करी। जब
अमेरिका
1
जाएगा
साल
वो, सुन,
तो
वो यहाँ नहीं रहेगा, वो यूएसएमएल देगा,
हाँ
शर्त
नहीं,
लगा।
वो यूएसएमएल देने के बाद की बात बता रही हूँ।
हाँ,
जो एक फेज होता है
yes.
उनका, जब जो
All
फेलोशिप
those
के बीच
students who
वाला,
want to go
वो
for
खाली
USMLE,
टाइम में कितना सारे
yeah.
पब्लिकेशंस कर पाया। मैं यही कह रही हूँ कि ये आने वाली जनरेशन को इसकी इंपॉर्टेंस पता है, कैसे करना है, कैसे डेटा प्रिपेयर करना है। हम लोग तो एक अपने मेरे फेलो को मैं करवाना चाह रही हूँ, तो उसी में ही डेटा कलेक्शन में ही हम लोग इतनी एनर्जी लग जाती है हमारी, उसके स्टैट्स कैसे इकट्ठे करने हैं वगैरह वगैरह। सो वो एक सिस्टम में अगर आप आ जाते हैं ना, तो ये नई जनरेशन में देख रही हूँ कि कितनी तेजी से इस चीज को कर रही है। और आने वाले 20-25 सालों में तो इंडियन डेटा का बहुत बाढ़ लगने वाली है, एंड देन वील बी हैप्पी। तब हमारा कर्क्यूमिन वाला भी स्टडी जो है वो अच्छी सी होगी।
May your words be
हमें
true.
बता रहा है जो हम जब के एजेस से यूज कर रहे हैं इसको।
एग्जैक्टली मैम।
Yeah, great.
Thank you everyone.
Thank
Thanks
you
for
so
really
much,
joining
everyone.
in and coming and really, giving your insight into this subject, and very good discussion. Really enjoyed, and I would like to meet all of you physically in Dehradun or in Uttarakhand, anywhere you are doing somewhere at some point of the time. So wish you all a happy Ganpati festival. Like in our part of the country, is like everywhere today there's a Ganeshji, and Ganpati Bappa Moria. So that's what is happening. So thank you, and thank you all my coordinators, Dr. Akriti, Dr. Kalyani, Dr. Rudri, and UNS team for giving a seamless platform to carry this important discussion and scientific deliberations. Thank you, everyone. So see you soon.
Thank you and wish you all
Thank
the
you
best,
very
Doctor.
Thank you all of you.
Thank you, everyone.
Nice
Evening to
creative
you,
session.
and especially
Thank you,
Dr.
Auntie,
Saini,
Dr.
Dr. Anupma, and Dr. Surbhi, Anuja, everyone.
Thank you, ma'am. Thank you, everyone.
Thank you, ma'am.
Thank you.
Thank you, Shilpa. Thank you, ma'am. Thanks.
Bye-bye.
Thank you.
Bye, everyone.
Thank you, Archana, ma'am.
Recording stopped.